I'd like to welcome Dr. Venugopal to start the evening session.
All right, thank you, Raymond. Just going to share my screen.
Are you able to share screen? Yep, great, fantastic.
Are you able to see my slides?
Yes, we can. Fantastic, thank you.
All right, thank you once again for inviting me for this session. So today I'll be talking on updates in management of osteoporosis. So learning objectives today, following the talk, you'll learn how to diagnose and screen osteoporosis. You will be able to assess efficacy and limitations of current osteoporosis therapies. And finally, we need to understand how to implement the sequential approaches to osteoporosis management. So what is osteoporosis? It's when we have low bone mineral density, and that actually means that there is a defect in the microarchitectural deterioration of bone tissue. So you will have decreased bone strength, increased bone fragility, and increased fracture risk. So usually patients are asymptomatic if you've seen them. The diagnosis is usually made after a fracture. But at least in primary care, we would want to identify our patients at risk and prevent fractures before it happens. Some of the other clinical presentations include when they have dorsal kyphosis or scoliosis or spinal deformities. They may have low trauma fracture or fragility fractures. And that means if they have a fracture following a fall from a standing height. Some patients, especially elderly, may have loss of height and sudden unexplained back pain. So when they present with unexplained back pain and they have risk factors, we might want to ensure that they have not had a vertebral fracture. So how do you classify osteoporosis? So osteoporosis is when the T-score is less than 2.5 on the bone mineral density. And osteopenia is when it's -1 to -2.5. Severe osteoporosis is when the T-score is less than -2.5 and patient has one or more fragility fractures. So unfortunately, most of the time we see patients at this stage when the osteoporosis is severe and they've already had fracture. So why do we pick the threshold of T-score of -2.5 and below? So that actually identifies 95% of young adults at highest risk of fracture. So if you saw the bell curve, patients with the T-score of less or equal to -2.5, majority of them, at least 95% of them, would be at higher risk for fragility fractures. And that's on the bone mineral density. So how do we diagnose osteoporosis? Gold standard is bone mineral density using the DEXA scan. But if you have a patient who's actually had a low trauma fragility fracture, means any fracture fall from standing height at any site, you might want to suspect if they have osteoporosis. And once that happens, then you might want to exclude secondary causes of osteoporosis, especially in a younger patient. So primary osteoporosis is usually a postmenopausal osteoporosis. This is what we see in women after menopause due to loss of the protective effect of estrogen. So they have accelerated bone loss following menopause. Age-related osteoporosis may occur in both men and women. Unfortunately, after menopause, it's accelerated in women. In men, it's more common after the age of 70. If you cannot identify a cause, it's idiopathic, but this is very rare. Secondary causes of osteoporosis include endocrine causes like Cushing's syndrome, or patients who have hypogonadism of their thyrotoxic, or if they have other conditions like hyperparathyroidism. If patients are on steroids, then they would also be at higher risk of reduced bone mineral density. And if they've been on steroid therapy for more than 3 months, at least a prednisone dose of more than 5 milligrams daily, then they would be at risk for osteoporosis. So other risk factors would include if patients are on immunosuppressants, or if they're on TZDs, or if they're on aromatase inhibitors or androgen deprivation therapy in oncological issues. Patients with liver disease or chronic renal impairment are also at high risk for low bone density and osteoporosis. So these patients, you might want to screen them. And of course, if they have nutritional deficiencies or multiple myeloma or malignancies. So this is something that's very common. If you have patients who are on steroids, so some patients are on many other, they have many other conditions, rheumatological problems, or even they have severe asthma, they have connective tissue disease, and they may be on prolonged course of steroids. So you do want to consider if they may have glucocorticoid-induced osteoporosis. They've been on a prednisone dose of 5 to 7.5 milligrams daily, or is equivalent, for more than 3 months. So bone loss actually occurs very quickly within the first 6 to 12 months of oral glucocorticoid therapy. How do you diagnose? You actually may not need the bone mineral density for diagnosis, but it will support your diagnosis. If your patient is on a high dose of steroids for more than 3 months, then you might want to make a presumptive diagnosis of glucocorticoid-induced osteoporosis, especially if they are older. When we look at the DEXA score, the measurement at the hip actually provides the best assessment of fracture risk. Sometimes when patients are on steroid, there may be discordant changes with the spine. And if they have degenerative changes as well, then at the spine, you can have falsely high bone mineral density result. If your patient has also had a spine fracture, remember when that area of fracture, the bone mineral density will be high. So when you interpret the BMD, you want to exclude that region of fracture. And that includes patients who've also had any spine intervention as well. So who would we consider assessing or screening with a bone BMD? So patients who are younger than age 50, if they've had a minimal trauma fracture, or any patient with minimal trauma fracture, you might want to consider if they have low bone mineral density or osteoporosis. And usually when they're younger, they have secondary causes for bone loss. Also, if they have other diseases or conditions associated with bone loss, and if they were on any of the other medications that I mentioned earlier, if you have reason to suspect hypogonadism in men, or again, patients on following androgen deprivation therapy, in men, you might want to consider screening them for osteoporosis. Again, older patients who are at risk for falls, they may not complain of pain. You might want to screen them. So screening, at least for men over the age of 70 and for postmenopausal women. So again, we do want to try and detect the osteoporosis or try and prevent fractures. So how do we prevent fracture risk, especially when we screen them with the bone density? So we have fracture risk algorithms in Australia. So we have two risk calculators that we can use, and these are available online. That's the link for the online calculators. So the Garvan fracture risk calculator and the FRAX tool. So the FRAX tool is population specific. You can use it for Australia or for any other country. And the advantage is that we can also apply it for populations in Asian societies as well. For example, if you have a patient who is a Asian or who has emigrated to Australia from another country, they haven't actually grown up here, you might want to consider using the FRAX risk assessment tool, looking at population-specific ranges. So they predict individual fracture risk. What's the difference? So the Garvan fracture risk calculator, like I mentioned, is mainly for local population. So the data that you input in the calculator includes age, their gender, their T-score, the bone mineral density, if they've had any previous fractures or falls in the last 12 months, you want to include that. The FRAX calculator actually looks at more parameters. So it also looks at history of parental hip fracture, other risk factors, modifiable risk factors, for example, if a patient is smoking. It also looks at if your patient is on steroids and if they have other secondary causes, such as rheumatoid arthritis. And of course, I mentioned you can adjust the calculator based on country and ethnicity, which can be more accurate. So this is what the calculator looks like. So I've included the link, or even if you go online, you can search for this easily. You can input all the parameters and then it will calculate the fracture risk for a patient. So you will need to have at least a bone mineral density to calculate the fracture risk. And this is what the FRAX risk assessment tool looks like. So you input all the parameters in. You can change the country as well. And it will, again, provide you with the fracture risk. So treatment threshold, when you use the FRAX calculator, is if they have major osteoporotic fracture over the 10 years risk, if it's more than 20%, if the 10-year risk of hip fracture is more than 3%, then even if they have not fractured, and this is the result that you obtain from the risk calculator, you might want to consider initiating therapy. So as I mentioned, for the FRAX risk assessment tool, we actually do not require the bone mineral density. But it can improve the prediction of fracture probability, because remember, we're looking at all the other risk factors as well. So patients with osteopenia, I've mentioned this earlier, so fracture probability of more than 3%, so 10-year risk at the hip, and if it's more than 20% for major osteoporosis-related fracture, then you might want to consider initiating therapy for patients who are osteopenic, who haven't fractured yet. And how do we utilize bone turnover markers in clinical practice? I notice some doctors routinely measure the bone turnover markers. So at diagnosis, there is no reason to measure them. So bone turnover markers, we actually use them more to monitor therapy. And again, it depends on what treatment your patient is on. For example, if they are on a weekly anti-resorptive therapy or a daily anti-resorptive therapy, then sometimes if compliance is in question, then the bone turnover markers can be useful. And if such patients, if their bone mineral density has not improved after about 1 or 2 years of therapy, then you might want to look at the bone turnover markers. If your patient is on an annual zoledronate, again, you know they're actually getting the treatment. So it's not really a question of compliance. So you may not actually need to do the bone turnover markers. And that's the same with patients who are on Prolia, 6-monthly injections. And most of the time they see their primary healthcare provider for the injections. We don't actually need to do the bone turnover markers unless you're suspecting accelerated bone loss due to other reasons, or if compliance is an issue. So with that, I'll just discuss a patient just to see how we can apply the risk calculator. So I have here a patient who's a 58-year-old female who's referred for low bone mineral density. She's got a history of ovarian cancer, which is now in remission. So she had a TAPSO done, and she was on hormone replacement therapy. So with the TAPSO, so they have had removal of the ovaries. You know, they would have estrogen deficiency. Stopped HRT at age 55. So a smoker, has 2 to 4 glasses of wine. So all these are other risk factors as well. And if you use the FRAX calculator, you can input all of these data into the calculator. And again, this is someone who's come with no history of fractures. And this is a bone mineral density. So if you look at it, it's not actually at the osteoporotic threshold, but it is osteopenic at the femoral neck. So now the question is whether this lady, she's relatively young, she's 58, whether she would actually benefit from anti-resorptive therapy. So if we input all the parameters into the FRAX calculator, what we can see is her risk, 10-year risk for major osteoporotic fractures, 3.5%, and hip fracture risk is 1.5%. So if you use the FRAX calculator, then you may not be inclined to start therapy, because the threshold for treatment is if it's more fracture risk is more than 20% for major osteoporotic fractures, and if hip fracture risk is more than 3%. You do use the Garvan calculator, so that changes things a little bit. Hip fracture risk within 5 years is about 1%, so you may not really be looking at hip fracture risk 5 to 10-year percent. But the risk for the 10-year risk for any other osteoporotic fracture, again, is about 3% and 14%. So that's just at the treatment threshold. The question is whether to treat or not to treat. Now, this lady is postmenopausal, and it's 10 years after menopause. She does have osteopenia. So what do the guidelines say for these patients? So if they have been menopausal for more than 10 years, 10 years or more, and they have osteopenia, then we should consider bisphosphonate therapy for primary prevention of vertebral fractures. Again, the evidence level is grade C. So if you would like to watch and wait for this patient, you wouldn't actually be wrong, because what you would do is you would still do a bone mineral density monitoring every annually or every 2 years. But to prevent risk of fractures, you are not wrong in starting treatment either. So how do you manage osteoporosis? So we have non-pharmacological intervention. So that includes adequate calcium and vitamin D intake. Of course, you have the other modifiable risk factors that you want to look into. So limitation of caffeine intake, stop smoking, avoid excessive alcohol, and regular exercise. So the exercise that we recommend is weight-bearing exercise. So if patients are bedbound, or even if they're on a wheelchair, because they are not mobilizing as much, so especially patients on wheelchair, you find that their hip bone density can be lower. And that includes patients who are not actually mobilizing. So again, if you have elderly patients who are not mobilizing, you might want to do the bone mineral density. If that is low, you do want to consider treatment. I have had questions from colleagues, patients are bedbound anyway. Is there any need to start anti-resorptive therapy if they are bedbound? Because, what's going to be the risk of fall? Again, even if you're bedbound, they can always be at risk of falling from the bed, or even a minor trauma, even if you're handling them. So they would still benefit from anti-resorptive therapy. So how much calcium do we need? So most patients, or most people, most of us actually get about 800 to 900 milligrams of calcium in our diet. And the evidence does show that the optimum calcium level would be about between 1,200. So that would be the optimum level. Between 800 to 1,200, this would be a good level. There's actually been found to have there's no benefit in providing them excess calcium because it has not been found to reduce fracture risk. So when we talk about calcium intake, you want to include the overall calcium, including what's in the diet. So if you are getting about 800 milligrams from the diet, then you probably just need about 400 and 500 milligrams of calcium a day. So when we look at the relationship between calcium fractures and if we look at adjusted all-cause mortality rate, so this is what I mentioned. Most of the time, the calcium levels, if their intake is between 800 to 1,200 milligrams daily, so that would actually be ideal. And if we look at mortality in relation to vitamin D, so between 75 to 125 nanomoles per liter, this would be the ideal level. So you find that mortality rates actually increase when the level is below that, and also if it's above. So this is what you want to aim for. So I always do advise my patients for optimum also PTH, physiological PTH suppression, and also for optimum bone health, we'll aim for vitamin D levels of at least 75 nanomoles per liter and above. Of course, deficiency is when is under 50, and sufficiency, of course, if you're looking at rates levels more than 50 nanomoles per liter. But when we look in relation of mortality, longevity, these would be the ideal levels to aim for. So this is the osteoporosis risk assessment, diagnosis and management algorithm that you would be familiar with from the RACGP guidelines. So what we talked about is if they have minimal trauma fractures, then you might want to consider treatment. DEXA can be supportive, but once they have a minimal trauma fracture, you do not want to delay therapy. And that is at the hip or vertebral fracture. So in primary health practice, you can actually initiate treatment at this level. If they have minimal trauma fracture in any other sites, so that's other than the hip vertebra, then you might want to consider referral for specialist review. The reason being that in most cases, there might be secondary causes for osteoporosis in these patients. You do not want to miss things like hyperparathyroidism or any localized disorders that can cause fractures at other sites. Osteogenesis imperfecta in younger population can cause multiple fractures in others. Now, if they have no history of minimal trauma fracture, we've gone through this. So if they have all these risk factors, premature menopause, hypogonadism, falls risk, we went through that in the table earlier, you might want to do a DEXA of the spine. So for men, if they are over the age of 70, you would want to look at the bone mineral density because, again, they will have bone loss, which is age-related. Again, pretty straightforward. If the T-score is less or equal to 2.5, again, we want to start initiating therapy. And if it's not, if they're osteopenic, then you can actually apply the fracture risk calculator that I mentioned earlier. And if from the fracture risk calculator they're at low risk, you want to monitor them with usually 2-yearly bone mineral density, because when you do it under 2 years and they don't have any secondary causes, you will not be eligible for a Medicare rebate, and patients might need to pay out of pocket for the bone density. So in general, most of the time we monitor them with 2-yearly bone mineral density. All right, so I'll come to the treatment types that we have. So of course, first line is bisphosphonates, as mentioned in the guidelines and our flow chart. So the bisphosphonates approved for use in Australia are alendronate, risedronate, and zoledronate. So alendronate and risedronate, these are oral agents. Zoledronate, IV aclastar, is a parenteral or IV agent. So the evidence for alendronate has been there because it's the first line. So it reduces the rate of new vertebral and hip fracture by more than 50% in women. That was seen in the initial fracture intervention trials. And you can see fracture reduction risk is seen after at least 12 months of treatment. So benefits actually are seen up to 10 years if it's clinically indicated. Risedronate, so there's either a daily preparation or a weekly preparation. Again, it improves both lumbar spine and femoral neck bone mineral density. And the advantage of risedronate is that they have less gastrointestinal side effects. So with oral bisphosphonates, if your patients have gastritis or gastroesophageal reflux disease, you might want to pick an agent that does not exacerbate that. So risedronate would be a better option. We have enteric-coated risedronate as well. So both alendronate, risedronate, they come in a daily or weekly preparation. Most of the times I prefer to give my patients weekly preparation for convenience and compliance sake. So to prevent the GI side effects, you want your patients to take the medication first thing in the morning on an empty stomach. They need to remain upright for at least 4 hours to prevent reflux. So again, oral bisphosphonates, if your patients are bedridden, may not be the best agents because that will exacerbate reflux. Zoledronate is a parenteral agent, so most of the time we administer it yearly. The dose is 5 milligrams. So infusions usually over 15 to 20 minutes. And again, very good evidence for vertebral fracture reduction and also hip fracture reduction, and also in other non-vertebral sites. And IV zoledronic acid is useful when patients really are not able to tolerate oral bisphosphonates, or if they have severe reflux symptoms, severe gastroesophageal reflux disease. You're all familiar with Prolia. Again, it's a very popular agent for osteoporosis treatment. It's convenient, 6 monthly subcutaneous injection. So it's a human monoclonal antibody. It inhibits the formation of osteoclasts. So again, very convenient. So it actually it prevents the rank ligand from activating its receptor. So it's an anti-resorptive agent. So the evidence for use in Prolia, you can use it first line for treatment of osteoporosis in postmenopausal women. And it is used as alternate therapy for men. So second line therapy in men for management of osteoporosis or their increased risk of minimal trauma fracture. So denosumab is not any more potent than the bisphosphonates. So they are both anti-resorptive therapies. They just have a different mechanism of action. but the way they work is at least to inhibit osteoclastic activity. So if you're talking about first-line treatment, you'd want to pick either oral bisphosphonate, or you want to consider Prolia. And I will come to how we can decide on which agent would be better for your patients as we go along. So I have another patient here who is a 75-year-old lady diagnosed with osteoporosis in 2015. So she was actually started on weekly Fosamax Plus. No history of fractures, because at that time her bone BMD actually showed osteoporosis. So she's over the age of 70. T-score at lumbar spine was -2.8. So she would be eligible for anti-resorptive therapy covered by the PBS. So she started on Fosamax Plus. But she has been on treatment for many years now. So in 2020, this was her bone mineral density. So still an osteoporotic range, but the question is about side effects of bisphosphonates. So do we cease therapy? The bone mineral density or the T-score seems to have improved, but would we consider ceasing therapy for this patient who's been on treatment since 2015? So we'll come to that in a moment. So this is the other concern with prolonged use of bisphosphonates. Atypical fractures of femoral shaft. So again, if you've been using anti-resorptive agents for more than 5 years, then there's always a question as to whether your patient would be at increased risk for atypical fractures. But we must look at the weigh the risks and benefits of therapy. So at the data actually shows that the absolute risk of atypical fracture is low. So it's 1.9 to 8.4 per 10,000 patient years. So with long-term use. And I mentioned that the anti-resorptive agents can be beneficial for up to 10 years. So with alendronate, we have data to say it can be beneficial for up to 10 years. So the other adverse event, quite serious, that we are concerned about for anti-resorptive therapy, and that includes both bisphosphonates and with Prolia or denosumab, will be osteonecrosis of the jaw. Again, this is very rare complication. The risk is ranges from 0.01 to 0.04%. Again, 1 in 8,470 patients. So to less than 1 in 100,000 patients for those on oral bisphosphonates. So it is a very rare complication. Again, for some patients who may be at high risk or we are concerned most of the time, if we are to start on anti-resorptive therapy, I always do talk to my patients as to whether they have any dental procedures planned. And we want to get that sorted first before commencing anti-resorptive therapy. So if they are on denosumab, again, what we do is we will time, and if they require a dental procedure, we time the denosumab injection to be done after the dental procedure. So then 6 monthly injection, then you might want to delay the denosumab until after the procedure is completed. So how do you identify atypical fractures of the femur? So I've been an endocrinologist for 10 years. I've only seen one case of this. Again, that patient had very severe secondary osteoporosis as well. So symptoms would be if they've been on long-term anti-resorptive therapy, and if they complain of mid-thigh pain, so even before they fracture, they have mid-thigh pain, you might want to do an X-ray. for them of the femur. So they can have minimal or no trauma. And the fracture line usually originates in the lateral cortex. So initially you would see a beaking appearance associated with pain. And then the fracture actually just goes right across. It may be incomplete fracture. It can also involve the lateral cortex. Usually it's not comminuted, but sometimes you can have some comminuted fractures. So the beaking again is the first sign. So these are major criteria for the fracture. Minor criteria would be there's increase in cortical thickness of femoral diaphysis. They have some prodromal symptoms that I mentioned, just mid-thigh pain. So you want to really look at the X-ray and look for changes. And if they have any delayed fracture healing over the site. So clinical setting, if they have mid-thigh pain, they've been on anti-resorptives for about 5 years or more, you might want to do the X-ray just to look and see if there's any changes, especially at the lateral cortex. And this is what I mentioned about the incidence. So usually with prolonged long-term use, but you can see that the risk outweighs the benefit. So the number needed to harm is about 667, but for patients, the number needed to treat is about 91, and for vertebral fractures, about so again, if they have been on therapy for prolonged duration for more than 5 years, then you might want to consider or be cautious if they might be at risk for atypical fractures. Again, you look for the minor and major criteria. Most patients tolerate oral bisphosphonates well for up to 10 years. So when you talk about long-term efficacy of bisphosphonate therapy, so look at alendronate, zoledronate, and risedronate. Again, we look at, this is the data from the fracture intervention trial and the extension trial for up to 10 years. So even following the long-term duration, you can see there's significant reduction in fractures versus placebo. And that's the same as zoledronic acid. So we have data for up to 5 years. Again, significant reduction in development of new fractures. And the same with risedronate. So risedronate, there is safety data for up to 7 years. So on average, up to 5 to 7 years for risedronate, alendronate, the safety data for up to 10 years. So that being said, how do you select candidates for drug holidays? So you don't want to keep your patient on bisphosphonate therapy forever. You do want to assess them. So once you start them on treatment or anti-resorptives, you want to do the bone density at least every 2 years. If they have secondary causes, then that's when you do it annually. So if they've been on oral bisphosphonates for at least 5 years, and if they are at high risk, that means when you look at the BMD, the T-score is still less or equal to minus 2.5, or they have history of previous fracture of the hip or spine, or they have secondary osteoporosis, then for these patients, you might want to consider continuing bisphosphonate therapy. So again, up to 10 years, so you monitor them and look for improvement in the bone mineral density. And that's the same if they've been on IV zoledronic acid for up to 3 years, then you might want to consider drug holiday. Zoledronic acid, most times, I would consider giving it to them for up to 5 years, especially if they're very high risk or they have had history of multiple fractures. They're not at high risk, BMD has improved, maybe just one history of one previous fracture or no fractures in the past, then you can actually consider drug holiday, and then you can monitor them just with the bone mineral density every 2 years. So what if your patient had been on Prolia? So we talked about starting first-line anti-resorptive therapy. So you can pick either bisphosphonates or you can pick denosumab. And I mentioned before, denosumab is a popular agent, very convenient, 6-monthly injection. You do need to make sure that your patients have adequate vitamin D, because if their vitamin D levels under 60 and you are on denosumab, that can worsen vitamin D deficiency and worsen hypocalcemia. But if they're on denosumab, can we go on a drug holiday? Unfortunately, drug holiday is not recommended if you're on denosumab. So you can see once you cease the denosumab, there's actually a very rapid decline in bone mineral density. And they actually will be at increased fracture risk within 3 months of ceasing the denosumab therapy. Even if they do fracture on denosumab therapy and you want to consider alternate therapy, during that time where we are changing from denosumab to alternate therapy, they are at least at increased risk of fracture. So who would be a more appropriate individual for denosumab therapy? I tend to use it for patients who are older. Denosumab most of the time will need to be continued indefinitely or long-term. There is safety data for use of denosumab long-term compared to bisphosphonates. And again, if the patients really have gastrointestinal effects or they can't tolerate oral bisphosphonates, I would still prefer IV a cluster first before considering denosumab for younger patients. So younger would mean someone under the age of 75. Because again, once you start them on denosumab, it's best to continue it indefinitely. So this is what I mentioned, what happens when you discontinue denosumab. So in the FREEDOM study of the extension trial, they looked at discontinuing denosumab in patients on placebo, and of course the patients on the drug. We can see compared to placebo, there is a higher risk of vertebral fractures and more rapid decline in BMD. That's compared to placebo. All right, so when we discuss our previous patient, so the lady earlier who had been on Fosamax for up to 5 years, so her T-score was still less than -2.5. Again, if there's no concerns, then we can actually continue anti-resorptive therapy. What we would do is we repeat the bone density in 2 years and see if that has improved. Maximum duration of anti-resorptive therapy if someone's on bisphosphonates for up to 10 years. All right, now we have another patient. This is a 64-year-old male with rheumatoid arthritis since 2017. Now this patient has got very bad arthritis. He's steroid dependent. He's got multiple bony deformities and secondary osteoarthrosis. So just from the scenario, you can identify someone who's got multiple reasons for secondary osteoporosis. He's got steroids, and that will cause bone mineral BMD decline. He's also got rheumatoid arthritis. He was first diagnosed with osteoporosis in 2018. Again, at that time, he started on Fosamax Plus. So because of the glucocorticoid-induced osteoporosis, you've got low BMD, you would want to start anti-resorptive therapy straight away. So unfortunately, while on anti-resorptive therapy, 1 year later, he developed an L5 compression fracture. So he was referred to bone clinic for further management. Now, question here is, are we going to escalate treatment, or what do we choose as the next form of treatment? So these are sort of patients that you might want to consider getting a specialist consult or specialist involvement relatively early. These are all his medications. So you can see he's on methotrexate. He's already on calcium. He's also on prednisone. So in men, more than 50% of the time, there are secondary causes. So if a man develops a fragility fracture or minimal trauma fracture or fracture following a fall from standing height, we have to investigate and look hard for secondary causes, especially if they're under the age of 70. We do have to screen them for hypogonadism. And if they do have hypogonadism, then androgen therapy may be beneficial. However, if they have had a fragility fracture before and they have established osteoporosis, and especially if they are older, then we may not be able to just depend on the androgen therapy alone, which may not be sufficient. They may need both androgen therapy as well as anti-resorptive therapy. So if you look at this patient from 2018 to 2019 and in 2020, if you look at the T-scores, despite being on treatment for Fosamax, it has not really improved. You can see the T-scores very severe. Minus, less than -3. Even in 2020, seems to have improved somewhat, but the L4 is still less than L2, L4 is still less than -3. Neck of femur is still very severely osteoporotic. And the Z scores actually look at the scores in relation if they are matched to age. So it is less than 2.5, then you can deduce that the BMD decline is more rapid for this patient's age. So usually, if patients have secondary causes of osteoporosis, their Z score will also be less than 2.5, as in the bone mineral densities inappropriately low or there's accelerated loss compared to others in their age group. So secondary causes, usually you have T-score, which is low, less than 2.5. So we can conclude that the patient has severe osteoporosis. So what's the optimal management for patients with severe osteoporosis? The sequence of therapy important? Should we consider combination therapy, and how do you decide between anabolic agents? So when we look at current therapies for osteoporosis, we know we have anti-resorptive agents and anabolic therapy. Now, in primary care practice, most of the times we would be commencing patient on anti-resorptive treatment, and you're all very familiar with this. You actually do start your patients who are at risk from bisphosphonates, oral bisphosphonates. If they require parenteral or IV bisphosphonates, then you might refer them to a hospital or a specialist practice. And of course, denosumab, something that you are familiar with, and you start your patients on denosumab. But it's also important to identify patients who are very high risk of fractures and identify as to whether we might need to be more aggressive with their treatment right from the beginning, as to whether early anabolic therapy might benefit certain groups of patients. So this is the newest agent that we have now, romosozumab or Evenity. This was actually approved, or it's on the PBS since March last year. Teriparatide is the other anabolic agent that we have. So what we have was approved, covered by the PBS, is Terosa. So you can see, compared to the anti-resorptive therapy, they have significant increases in bone mineral density at the spine, up to 8 to 10%, and then hip as well. Hip is the teriparatide is actually comparable to the other agents, but you can see with romosozumab or Evenity, it's actually doubles the BMD at the hip, and that is after 12 months of treatment. So I talk about anabolic therapies for osteoporosis. We have, again, I mentioned, what we have is romosozumab or Evenity that's available in Australia. It's a US agent. And we have Tirosa or teriparatide. Abaloparatide is actually not available in Australia. So these agents actually increase bone formation. To some extent, they may inhibit osteoclast activity as well. So teriparatide is something that we are familiar with. Most of the times in primary care, if your patients actually have a fracture on anti-resorptive agents, either on bisphosphonates or even if they fracture on denosumab, what I do tend to see is referrals to consider teriparatide. So teriparatide is a potent anabolic agent. As we know, we can use it for up to 24 months, but the PBS actually reimburses its use for up to 18 months. So it's indicated in severe osteoporosis or osteoporosis not responsive to other treatment. So of course, if your patient, we look at the guidelines recommended to reduce fracture risk, who have sustained multiple fractures on anti-resorptive therapy. So your patients would at least have to be on anti-resorptive therapy, either denosumab or bisphosphonates for at least 12 months before the PBS will reimburse it. Romosozumab, as I mentioned, is the newer agent. So it is a monthly subcutaneous injection. It comes with 2 syringes at each time. So the dose is 210 milligrams a month. So each syringe is 105 milligrams. So we inject it subcutaneously one after the other. So again, a very powerful anabolic agent, and it's reimbursed by the PBS for use up to 12 months for patients with severe osteoporosis. So how does it work? It is a human monoclonal antibody, so it binds to sclerostin. So sclerostin is actually an inhibitor of the Wnt signaling pathway, and the Wnt pathway is actually responsible for bone formation. So if due to the action of sclerostin, if it inhibits Wnt signaling pathway, then that actually inhibits bone formation. Romosozumab inhibits sclerostin, and that will increase bone formation and increase osteoblastic activity. So how does the new agent compare to all our existing agents? I've already looked at the table. It's a very powerful anabolic agent. So you can see when we look at BMD gains in the lumbar spine, it's actually much higher than even that of teriparatide. Of course, teriparatide, any anabolic agent, would be higher than anti-resorptive agent. When we look at the hip bone density, the alendronate actually performs slightly better than teriparatide, but again, with romosozumab, you have very good hip BMD gains. As I mentioned from the table earlier, teriparatide and bisphosphonates are comparable in terms of improving hip BMD. The benefit is more seen in the lumbar spine, but with the romosozumab or Evenity, you can see very good hip BMD as well. And again, it's the same with the femoral neck. Very good BMD gains at the femoral neck compared to teriparatide and also alendronate. So this is a study comparing romosozumab and alendronate for fracture prevention in women with osteoporosis. So as a double-blind study, so first part of the study, those patients who received alendronate every week, and then they continued to receive that after 12-month period. And the second study, patients received romosozumab for 12 months, and then subsequently they were transitioned over to alendronate. So you can see for patients who are actually on romosozumab initially, after 12 months, they have less incidence of new vertebral wrist fractures. And at 24 months, even after transitioning over into alendronate therapy, they have significantly less incidence of new vertebral fractures. And that's after starting them on Evenity or anabolic therapy first, followed by bisphosphonate therapy. So in postmenopausal women, we've already discussed, this is just the ARCH trial. So again, it's one of the key landmark trials looking at Evenity use in postmenopausal women. So again, compared to alendronate, you can see that there is significant BMD gains at the end of the study period. So 12 months and then 24 months. And this is even after they transitioned. So what about use in combination with denosumab? So the FRAME trial looked at romosozumab and patients were transitioned over to denosumab after that versus placebo. So again, 12 months therapy, either placebo or romosozumab, and then transitioned over to denosumab. So again, at the end of 12 months, you can see patients who were on the romosozumab, obviously compared to placebo, would have less incidence of new vertebral fractures. And again, for patients who transition from placebo to denosumab, obviously, because they were on an anabolic agent initially, they have very significantly less incidence of new vertebral risk fractures. So it's also been established to show good data for management of osteoporosis in men. So again, you can see significant BMD gains in the lumbar spine. This study is looking in comparison with placebo, and it's the same with the hip at the end of 12 months and femoral neck. So significant BMD gains in all sides. So how about with teriparatide? So romosozumab, in comparison to teriparatide, we already looked at how it is superior in terms of BMD gains at the hip and femoral neck in comparison with teriparatide. But you can see here, total hip BMDs improved femoral neck as well as lumbar spine, and is what I presented in the table earlier as well. A problem with Evenity, precautions for use, it would be the same as a cluster or even denosumab. We need to ensure adequate vitamin D status, because if their vitamin D levels are low, then it can actually worsen hypocalcemia. So we want to make sure at least their vitamin D levels more than 60 before we administer romosozumab. So in the studies, they had found 18% of patients who developed antibodies, and about 4 to 5% had neutralizing antibodies. So they have some hypersensitivity reaction. However, it's a new agent, and this has not actually been described in clinical practice. The incidence has been seen more in the clinical trials. In the trials, there were increased cardiovascular events. So patients who we want to consider for romosozumab therapy or Evenity, we might want to get a past history as to whether they have risk factors for cardiovascular events, stroke. And that's the same with both men and women. Osteonecrosis of the jaw and atypical fracture, it is the same. The risk is compared to denosumab and bisphosphonates. Again, we want to consider dental assessment before starting. So coming back, is the sequence of therapy important in severe osteoporosis? So If we switch from anabolic agents to anti-resorptives, we will have very good BMD gains. And that's been proven in multiple studies. But the only problem is for us, I guess, in sense of local practice, the way that we prescribe our medications are limited by what the PBS allows or what PBS reimburses for. So if you have a patient with very severe osteoporosis, multiple fractures, very low T-score, you know that they would actually benefit from an anabolic agent in the first instance. Unfortunately, if you look at the PBS criteria, they will still need to be on normal anti-resorptive therapy first for up to 1 year. But these are groups of patients whom you might want to consider specialist intervention earlier. In some instances, we are able to get approval, at least, or funding for these patients, either through our institution or some form of funding to start them on an anabolic agent first, rather than to wait for a new fracture to happen. Now, when you switch from bisphosphonates to anabolic therapy, you can have BMD gains, but they are modestly blunted compared to de novo therapy. So based on this principle, it is still feasible, and that's actually what the PBS criteria is based on. You want to keep your patients on anti-resorptive therapy for at least 12 months, even if they've had a fracture prior. And then if at the end of 12 months, they have a new fracture, that is when PBS may reimburse your patients for anabolic therapy. So it's not... It's not completely bad. It's just, if severe osteoporosis, they may benefit from anabolic agents first. Now, this is the issue. When you switch from denosumab to anabolic therapy, there will be a significant BMD reduction. What I mean by anabolic therapy here is what has been studied. So before Evenity, we had teriparatide. So if your patient was on denosumab and they fracture, it does not make sense to switch them over to an oral bisphosphonate. In most instances, we would switch them over to IV bisphosphonates. But again, during that time period when they are being switched, there will be a decline in bone mineral density. So there will be an initial decline in BMD, so as in they will lose all their previous BMD gains before regaining it back on IV bisphosphonates. Unfortunately, you switch them over to teriparatide, then the BMD decline is accelerated. So as you'll see in this study, it's a data switch study. So they randomized women into 3 groups. So women who were on teriparatide, completed 2 years of teriparatide, 2 years of denosumab, and in a trial setting, they also looked at women on combination therapy. So after 2 years of teriparatide, they switched to denosumab. After 2 years of denosumab, they switched to teriparatide. And then combination therapy, they just switched to denosumab. So these were what the results show. So when you switch from teriparatide to denosumab, you can see you still have bone mineral density gains, and that's in the lumbar spine, and also in the femoral neck, that's the blue line. And again, same, we're looking at distal radius and even the total hip. So teriparatide to denosumab, so anabolic agent first, denosumab, you still have bone BMD gains. And that's the same seen in combination therapy, you have BMD gains. Unfortunately, a combination therapy is actually not the standard of treatment at this point in time, even though there's evidence that it improves BMD, but it's still not the standard of treatment. Now, when you switch over from denosumab, so patients have completed 24 months of denosumab, and now we are switching them over to teriparatide, you can see there is a decline. So initial decline within 6 months of the bone mineral density, and then it increases after that. And that is worse in the femoral neck and in the hip. So these patients actually, within the first 3 to 6 months, when you either switch them over to another agent, or when you cease the denosumab, they are actually at increased risk of both vertebral fractures and higher risk of hip and femoral fractures. So we try not to switch the patients over from denosumab. So they fail denosumab therapy. Teriparatide is not the agent to consider. Now, as I mentioned, romosozumab is a newer agent. So it has been studied after therapy with denosumab, and you can actually see that in studies after anti-resorptive therapy, if patients been on romosozumab or Evenity first, they actually have significant BMD gains compared to when they were on anti-resorptive therapy in the beginning. But like I mentioned, prescribing habits are influenced by what is allowed on the PBS. So denosumab, if following 2 years of denosumab, once they switched over to romosozumab, there will be an initial decline in BMD, but it's actually shown to improve BMD in both hip and the lumbar spine. All right, so combination therapy in management of osteoporosis, I mentioned that there is no role at this point. So this is a study just looking at combination therapy of denosumab and teriparatide. So it does make sense. So it's part of the data switch study. So it does make sense to combine therapy, and you can see that when you combine the agents or overlap the agents, they have significant BMD gains. But it is not our standard of treatment yet because we still do not have data regarding effectiveness in fracture prevention, which is why combination therapy is not on our guidelines. It is not our standard practice. What we have data on is that it improves bone mineral density, but we in turn need to see this translates to reducing fracture risk. All right, so just at my last few slides, so coming back to our patient. He has been on bisphosphonates for a long time. This is his T-score, it's very bad. We all agree he needs to go on to anabolic therapy at this point in time. So what would the best treatment option? So obviously we can't just maintain on calcium and vitamin D supplements, the bone mineral density will decline. And again, it doesn't make sense to start him on Prolia because again, they're both anti-resorptive agents. So not quite interchangeable. So if someone were to fail therapy with alendronate, we would not switch them over to denosumab, or vice versa. We would want to move up in the ladder of therapy. So obviously not continue Fosamax plus because the BMD is not improved. So we can either consider starting him on teriparatide, stopping fosamax teriparatide, or romosozumab. So any of these two options would be an option for that patient with very severe osteoporosis. But is the patient eligible for PBS reimbursement for anabolic therapy? We agree he actually needs it, but is he eligible for PBS reimbursement? So this is where it gets tricky. So for patients to be eligible for PBS reimbursement, and bear in mind these agents, both romosozumab and teriparatide actually cost about $400 out of pocket a month. So that's very expensive. So they actually have to have all criteria to satisfy criteria for PBS reimbursement. So T-score of less than -3, which our patient has 2 or more fractures due to minimal trauma. Unfortunately, this patient only has 1 fracture. He doesn't have 2 or more fractures. He did experience at least 1 symptomatic new fracture, at least 12 months of continuous therapy. So it's got 2 out of 3 criteria. So if you actually have called the PBS authority line, like we usually do, they will not, there are no exceptions. So when we do call the authority line, they'll ask for the date of the fractures, the site of the fracture. So you actually have to have all this information in handy if you're considering anabolic therapy. So unfortunately, this patient does not satisfy PBS criteria for teriparatide, even though he actually requires it. Clinically, he requires it. And it's the same for romosozumab. What is the PBS reimbursement criteria? So BMDT score -3, which he has. Unfortunately, has not had 2 or more fractures due to minimal trauma. He has experienced 1 symptomatic new fracture. This means that sole PBI subsidized therapy means that patient is not on combination therapy. So obviously, if someone were either on denosumab or bisphosphonate, you want to stop that treatment first and then start them on, romosozumab or anabolic agent. And romosozumab treatment must not exceed lifetime of 12 months, so PBS will cover them for 12 months, which makes sense. Most of the data does show that BMD actually improves significantly after 12 months of therapy. There is data for up to 2 years. And of course, if they have had teriparatide before, then you wouldn't want to switch over to another anabolic agent. We're still not at that point to recommend that as yet. So unfortunately, this patient, he can't actually be on what he's on. He definitely does need an anabolic agent. So again, these are patients, if you do refer to specialist practice or you identify they're very high risk, you refer them, what we can do is we will try to seek alternate funding or sometimes through hospital institution funding for reimbursement therapy, for anabolic therapy. But with the newer agent Evenity, there is something called a co-pay program. So the co-pay program actually is sponsored by Amgen. So Amgen is the company for Evenity and also for denosumab. So in the co-pay program, patients actually pay for Evenity for up to 8 months, and then the next 4 months, the medication is provided free of charge. So these are for patients like our man earlier. So he definitely needs anabolic therapy, but who's going to be able to afford $400 out of pocket every month? So this is something we can consider for our patients. Usually a specialist is authorized to enroll patients in the co-pay program. So if you refer them to specialist practice, we will actually see if they fit the criteria and we will enroll them in the co-pay program. So 8 months, unfortunately, still have to fork out 8 months worth of treatment. That's $400 a month, around $400 a month for about 8 months. And then the subsequent 4 months therapy is free. So there will be a program coordinator who calls them first. On average, they might end up spending about $2,000 a year versus $3,000 to $4,000 if they were funding it on their own. So this is an option. It's still an expensive option, but there is still some options for patients. Again, if they have very severe osteoporosis, just the PBS criteria alone should not limit us from deviating from best practice. Sometimes we do discuss with our patients what the best practice is, but unfortunately, because of PBS prescribing and funding cost of medications, we are limited by what we can do. But some patients, if they are able to afford, that is also an option that they might be able to pay out of pocket. Right. This is just a summary slide, a flow chart. So for postmenopausal women, again, this chart is incorporated the newer agent romosozumab. So they are actually at very high risk. You can actually consider anabolic agents from the beginning. And of course, this is not something that you would be doing in primary practice or general practice. If you do identify such patients, it would be good to refer them to specialist practice so that we can assist our patients in getting the best treatment to prevent future fractures. With denosumab, again, you can use it as first line, but remember, if your patients are younger, that is going to increase their lifetime exposure of denosumab. Denosumab usually, we might need to continue with indefinitely. If they fail therapy with denosumab or they have fractures on denosumab, right now the standard of care is we switch them over to IV zoledronate, or the better agent or the newer evidence has emerged that fracture risk is better prevented if they fail on denosumab. If they satisfy criteria, we can actually consider romosozumab or Evenity. So of course, for patients with a low risk for fractures or postmenopausal osteoporosis around the perimenopausal time, we can consider HRT or selective estrogen receptor modulators. However, these agents are more beneficial for patients who are at lower risk for fractures. So once they're at high risk, or once they've had more than one fracture, then you might not want to just depend on hormone replacement therapy. They may need anti-resorptive therapy. So once they have severe osteoporosis, once they have fractured, even if they're postmenopausal or around the perimenopausal age, the SERM or the estrogen replacement may not be the best option, or may not provide the best BMD gains for them. So in summary, key points: osteoporosis is often underdiagnosed because sometimes we've got so many things to do, we don't actually consider screening our patients at risk. So remember, if your patients are on steroids, always consider screening for glucocorticoid-induced osteoporosis. And patients with severe osteoporosis, we now know that the sequence of therapy does influence bone mineral density. So transitioning to anabolic therapy from denosumab, and that would be teriparatide, might lead to initial decline in BMD and increased fracture risk. So
thanks, Dr. Venugopal. I've got quite a lot of questions. I'm trying to track the questions between the chat and the Q&A, but we might have to do a rapid fire Q&A.
Sure, no worries.
So first of all, James asked, how long can we use Prolia safely for, and when do we have to stop? So I guess,
yeah, as I mentioned, Prolia, there is data for use long-term or indefinitely. So if I have a patient who I had started on Prolia, I would actually just continue it. And I always advise them that you may need to be on this lifelong. We monitor bone density every 2 years, because remember, with Prolia, when you stop or interrupt, or even when you switch, their BMD will decline. So for example, if you've done a BMD after 5 years and it has improved even to a normal level, if you stop the Prolia, the BMD will decline. So that is the problem with Prolia. It's a great convenient medication, but we tend to forget that once you stop, all that BMD gains that you get from it, you will lose it. So the other option is, if you don't want them to be on a long-term Prolia, if they're a younger patient, you definitely need to switch them over to something else. But again, switching over to oral bisphosphonate will cause a decline in BMD. So I tend to continue my patients indefinitely if they are on Prolia, if there's no issues.
All right, that was another related question. It was a question about, is it safe to switch from Prolia to oral bisphosphonate? So it sounds like it's your preference not too, because it's loss of.
So the evidence actually shows that they will have a decline in BMD. So when you select patients for Prolia, try to choose patients who are older. For me, I try to stick to patients who are over the age of 75, and those who really cannot tolerate bisphosphonates. That's when I would consider Prolia for them. So reduce the lifetime risk. If they are younger, 50s, 60s, or under 70, then I would try as far as possible oral bisphosphonates first. If they can't tolerate oral, then IV bisphosphonate, a cluster. A cluster is great. I know you need an infusion, but it's once a year, and after 3 years, you can consider coming, your patients can go on a drug holiday if everything improves.
And there were a couple of questions around drug holidays, but looking at the flow chart that you had at the end, it sounds like if they're at low risk, just reassess every 2 to 4 years. Is that right?
Yes. So if their BMD has improved, you can come off the medication, do the bone mineral density every 2 years, and then watch the trend from there. If there's a decline, because they will decline later as they age, because remember, as we all age, we have age-related decline, you can consider restarting. And again, depending on lifetime exposure of bisphosphonates, so if you've been on bisphosphonate 5-6 years, you can always restart that after a drug holiday, or they're older, you can consider denosumab.
Now, I'm going to apologize to our participants tonight in the chat. I'll just try and read through the questions as best as I can, just because there's quite a few questions that have been answered already. First of all, I'll read backwards. Is there a genetic risk for osteoporosis?
Well, patients who have osteogenesis imperfecta, they tend to have more fractures. Younger patients with neurological issues, you have to screen them for bone density. So osteogenesis imperfecta is the only genetic condition. There is no sort of genetic screen for osteoporosis. If your parent has had a hip fracture before, then you may be at higher risk for fractures. But there's not actually a particular gene that we can screen for. So family history is important, especially first degree relatives, females. And that is why it comes in the screening algorithm.
Great, thank you. There's a question around role of bone turnover markers in management of osteoporosis. You mentioned that it was sometimes to check for compliance.
Yes, that is what I mentioned. So bone turnover markers on diagnosis, there's no point doing it. So if your patient is on oral bisphosphonates, I do it sometimes, again, mainly to check for compliance. But if they're on 6 monthly denosumab and you are administering the denosumab, there's no question of compliance there. Again, a yearly zoledronate, so you may not need to do it unless you're suspecting there's other causes for accelerated bone loss. Then you might want to consider doing the bone turnover markers. But most of the time, it is not actually required. Required more of your oral bisphosphonates.
Yeah. And on the subject of Prolia, how often should we check calcium and vitamin D? And also, if they're hypocalcemic or low in vitamin D, should we postpone the injection?
Yes, you need to postpone a cluster or Prolia or even romosozumab. Their vitamin D is under 60, so need to be more than 60. So you want to make sure the level's more than 60. So you start them on a higher dose first. So they're deficient under 50. I would give them either 3,000 or 4,000 international units a day for up to 4 weeks, and then 2,000 international units per day for up to about 6 to 8 weeks. You measure the vitamin D in 2 months. Once they are on target, I always aim for more than 70. Then I maintain them on 1,000 international units per day. And then you don't actually have to keep monitoring it that often unless you're concerned about things like malabsorption. So usually every 2 months. So once you replete those vitamin D stores and you are confident your patient is on
Thank you.
Measuring it here.
Now, a specific question, a case from Bernadine, patient on 75 years of age on Prolia for 3 years, BMD minus 2.8 after 2 years, basically stable, no change. Should we consider change of treatment or keep going?
No, I would not. Like I said, if she has had no fractures, then you would still want to observe and keep going. Again, it also depends on all your other patients' risk factors. Is it declining? So again, if there's two consecutive decline, then you might want to look for reasons as to why there is a decline before switching therapy. So if your patient on Prolia is not improving, I would suggest these patients, you will need to refer them for specialist opinion, because just switching them over can be tricky. There can be increase in fracture risk.
Mm. Now, there's a couple of questions about younger patients and specifically with about eating disorder patients. So I might just read them out. So one is a patient, late 40s, eating disorder, MS, unable to remember taking meds. So currently on Prolia for 2 years. And then another patient, another case, best treatment for a 30-year-old female with anorexia and osteoporosis who does not have any other secondary causes identified, no history of fractures, refusing to see endocrinologist.
Okay, that's a very difficult situation. So again, it depends on what the threshold for osteoporosis is and how young the patient is. So the problem with bisphosphonates is A-cluster is actually a very good agent for patients who are younger with some secondary causes. But if they are planning for pregnancy and things, then this can be a bit tricky for them. Teriparatide has been shown to be useful in patients with severe premenopausal osteoporosis. But at the end of the day, again, eating disorders, we want to fix the nutritional deficiencies first. So make sure the vitamin D is adequate. As far as possible, if they have not fractured, it is addressing all those other risk factors, nutrition, weight-bearing exercise before considering anti-resorptive therapy. But I think you have a patient who's already on. So if they're already on, then again, you probably have to continue and continue monitoring the patient. That's for the denosumab patient. I wouldn't actually have considered denosumab unless they have renal impairment. So that's the other thing. You can't give bisphosphonates for patients who have renal impairment, GFR under 35. So that's when you can consider. So tricky, difficult situation.
And the role of like hormone replacement therapy or kind of the pill, I suppose?
Mild osteoporosis. So if they've already fractured, postmenopausal or already fractured, even the perimenopausal region already fractured, you can replace your hormones, and that includes men as well. You give them testosterone therapy, already fractured, they still need anti-resorptive to reduce fracture risk.
Yep. All right. We're coming up to 7:30, so I apologize that we can't get through all of the questions. And thank you so much for running through all the newest treatments. I've learned quite a bit about the anabolic agents tonight, which is really, really helpful. We've posted a reviewing performance kind of questions in the chat. Apologies, we were meant to go through some of the polls tonight as well, but there was such a massive amount to get through. So for our participants, we apologize we haven't been able to send out the polls in between, but if you could complete the reviewing performance update questions in the chat, that would be great. Just wanted to say thank you, Dr. Venugopal, for a really, really informative talk tonight. I was madly trying to take some notes myself, so it was fantastic.
All right, thank you, Raymond. Thanks.
All right. Have a great night.
Thank you.
Now, what I might do is give everyone maybe 5 minutes to take a breather, have a glass of water, but we'll go straight into the next talk with Dr. Vaishali Bhalerao, who will be talking to us about pregnancy complications and breast problems and case studies thereof. But let's everyone have 5 minutes, so we'll reconvene at 7:35. And if you could click on the link in the chat to complete the post-session reviewing performance updates in osteoporosis. I'm sure there'll be lots and lots to reflect on. Hi, everyone. I know that was a relatively short break, but I thought we'd get straight into it, given it's 7:35. So I'd like to welcome Dr. Vaishali Bhalerao, who is going to speak to us tonight about pregnancy complications, as well as some cases about breast problems. So Dr. Vaishali Bhalerao is a highly accomplished clinician with a remarkable journey in the field of medicine. Her career began at Sir GS Medical School in Mumbai, India, where she laid the foundations for her passion for healthcare. She completed a master's at the prestigious group of hospitals in Mumbai, and Dr. Bhalerao honed her skills and knowledge in one of the country's most renowned medical institutions. Dr. Bhalerao established her own private successful practice in Mumbai, where she served the community for 15 years, during which time she also held the position of associate professor in a state government hospital. Seeking further professional experiences, Dr. Bhalerao embarked on a journey to the United Kingdom, where she worked in the NHS, and her international exposure has certainly allowed her to broaden her expertise and gain valuable insights into different healthcare systems. Now, my understanding, Dr. Bhalerao, is that you're both a fellow of the Royal Australian College of GPs, as well as the Australian and New Zealand College of Obstetricians and Gynecologists. So thank you so much for speaking to us tonight. I'll let you take the floor.
Yeah, good evening all. Yes, I worked in 3 countries. In Australia, I'm working from 2011. And yes, I have got both the fellowship, FRSCGP and FRANSCOP, but I'm gynecologist originally, and I'm working more in ONG. All right, so Dr. Venugopal's presentation was really, really informative. Mine is going to be more interactive, and these are case studies. So that was a long, beautiful, informative presentation. So I'm not going to keep you waiting because it's almost 7:45, and I'm sure that you have got more things to do after we finish this presentation. So let's get on with our presentation. So let
Dr.
me share
Bhalerao,
this. Yeah.
I was just going to ask, could you turn on your video as well?
Yeah, sure.
Yeah, thank you.
I tried, but it says that you cannot start your video because host has stopped it.
Oh, okay. Nazia,
oh my God, I'm so sorry.
We might need some technical
I tried a few
assistance.
times.
I'm so sorry. Would you try now?
Yeah,
I
sure.
really apologize. And Dr. Yogis as well. I'm so sorry. This one is on me.
I tried twice.
Okay, lovely.
Cannot start your video. Okay, lovely to see you guys.
Likewise.
All right. Thank you for attending this webinar in middle of the week. I'm going to try to share my presentation. Give me a second. So share screen. All right. And slideshow. Just give me a second. No. So my mobile, this thing is not. Nazia, hello?
Yes.
Yeah, so I'm trying to, the thing is, I'll do this opposite way. Give me a second.
Okay.
Because the thing is, I'm trying to start a slideshow, but because the toolbar of Zoom is coming, I can't start that. Give me a second, I'll try a different way. Stop sharing.
Sure, absolutely, no problem.
We'll make this work.
It's all good. I am very intrigued. I've seen your presentation and I'm looking forward to a lot of interaction from everyone tonight.
Yeah, just give me a second again. Stop, share the presentation.
So what is it that you're inferring actually?
So the toolbar of Zoom is obstructing my slideshow. I can't, okay, from the beginning. Yeah, I fixed it.
Beautiful, amazing. Yeah. Okay, we'll start now.
Good, all right. So, so I've prepared this presentation as a tutorial. As a tutorial for health cert courses and regularly present them for educating GPs all over Australia, New Zealand, and almost 44 other countries through Health Cert webinars. The material obtained for this presentation is obtained from Health Cert presentations and various sources listed at the end of the presentation. Please feel free to go to those sources and explore more if you want more information. So I'm going to discuss 3 case studies for pregnancy complication, which is totally my topic, and breast problem, 3 case studies. Some of that is gynae problem, but these are the very, very common GP presentations. So I thought that I'll include them. So first is pregnancy complication, the case 1. A new patient, 37-year-old Kate, a primary gravida, has come to you with a history of 6 weeks pregnancy. This is an IVF pregnancy. Menstrual history, last menstrual period was 6 weeks ago. Past menstrual history, they were irregular and they were always a withdrawal period after a non-testosterone course. This is her first pregnancy after 6 attempts of IVF. Not an unusual presentation nowadays, isn't it? She's sexually active in stable relationship for 6 years. Till 5 years ago, she was using combined oral contraceptive pills for 13 years for polycystic ovarian syndrome and endometriosis. Again, very common presentation nowadays. Her past surgical history includes 4 laparoscopies for endometriosis treatment and comorbid obesity. What else we need to know about Kate? Do we need to know anything more? You can type things down or go through all the things which you would like to know. So yes, we need to know more things, like for example, medication history. So Kate is not taking other medication. Diet and exercise history. She's following healthy diet and trying to continue her exercise. Kate's family history. So she has got history of type 2 diabetes in her mother and aunt. And of course, we need to know about her examination. Vital parameters are normal and BMI is 36. Systemic exam, breast, thyroid, per abdominal examination is normal. So what are Kate's high risk factors for high risk pregnancies? Does she have any high risk factors? Yes, she does. So obesity, her BMI is 36. Past history of polycystic ovarian syndrome. Family history of type 2 diabetes. So what complication Kate can have? Yes, so she can have antepartum complications, intrapartum complication, anesthetic complication, and postpartum. So antepartum, she is at the risk of having miscarriages, congenital anomalies, gestational diabetes mellitus, hypertension, preeclampsia, micro or microsomia, increased risk of blood clots, deep vein thrombosis, obstructive sleep apnea, and even increased maternal mortality. Intrapartum, high rates of induction of labor, increased rate of instrumental delivery and failure of them, shoulder dystocia. So shoulder dystocia can be because of diabetes, gestational diabetes, especially because it is known that fetuses of mothers who have either diabetes or gestational diabetes, they put on more weight on their shoulders and then they get stuck. So that's why we need to monitor them and help them to have normal blood sugar. We'll go on with the complications. So other complications intrapartum, that they are at the risk of having more cesarean sections, postpartum hemorrhage, and peripartum death. Anesthetic risk, difficulties with attaining adequate analgesia, increased risk of general anesthesia, difficulty maintaining an airways or failed intubation, increased risk of ICU need postoperatively. Postpartum complication, difficulties establishing breastfeeding, deep vein thrombosis, wound infection and dehiscence, postnatal depression, long-term consequences for neonate, infant weight gain, neonatal body composition, and obesity. So what recommendation we need to give to Kate? So it's always better to have the recommendation in place right from beginning, because that there is a lot of evidence that it gives a good outcomes. So the recommendation what Kate needs is, first of all, she should be informed that how much weight gain she should be aiming for. So her BMI is 36. So any BMI more than or equal to 30, they fall into category of obese and they should be gaining maximum up to 9 kg of weight. Morbid obesity, more than 40, the weight gain should be allowed up to 5. So other recommendations, commence 5 milligram of folate and 150 microgram of iodine daily. Monitor for iron and vitamin D deficiency. Early GTT at 12 weeks, at first opportunity after conception, that is IDIP guideline, which we follow usually. And then repeat at 26 to 28 weeks of pregnancy if the first GTT is negative. Influenza immunization to reduce risk of major maternal morbidity in obese pregnant women. Close preeclampsia surveillance plus or minus aspirin depending on your local maternity unit guidelines, and dietitian and anesthetic review. Serial ultrasound scan in 3rd trimester for growth, and aim for delivery at 40 weeks. So that is case 1. I'm happy to take question at the end of each case or at the end of presentation. What would you recommend, Raymond?
Yeah, I think at the end of each case would be great.
Yeah.
So that it's fresh in mind.
Yeah.
And Bernadine's actually just put in a question. Are we supposed to routinely recommend iodine? Which I think you've put in the just
150
now.
microgram.
Yep, which is great.
Yeah.
And yeah, if everyone could just ask their questions, either put up your hands and we can do a live interactive chat. I can let you speak, or into the Q&A box preferably. Otherwise, chat is also fine. What's your view on the aspirin side of things?
Yeah. So I give aspirin. That is like, see, basically there is no definite Ranzco guideline. So, but then RCOG is also coming. Royal Ranzco guidelines are basically depending on RCOG guidelines, and there are some guidelines in RCOG that we can give low dose aspirin. So because there is no Ranzco guideline, it varies from hospital to hospital or the obstetrician to obstetrician. So where I work and in my private practice as well, I do give low dose aspirin. That means 100 milligram of aspirin every day. So especially those patients who had who are obese and those who had microsomic babies, shoulder dystocia, even though they did not have GDM, and also for those who had preeclampsia or those who have high blood pressure. So I do give aspirin to all these patients, low dose, as soon as we find out that they are pregnant.
And I believe there's an optimal kind of timing as well that you have to start before, was it 12 or 16 weeks for our optimal
16 weeks.
benefit? 16 weeks. Yep.
Yeah. So the thing is, we do come across these patients sometimes late. So sometimes we do consider sometimes to start them as late as even 22 weeks.
Okay.
Because the problem with this is that we don't have big evidence to support that how they are doing, but it's not going to harm. So and this will be continued till 36 weeks of pregnancy.
Yeah. Okay, that's really good to know that we can start late as well.
Yeah.
Now a few questions coming in Q&A. So since her risk of preeclampsia is high, should we also add calcium supplements with aspirin?
Yes. So basically, I have not discussed hypertension because it itself is such a huge topic, and we can organize whole presentation on preeclampsia or hypertensive disorder. It can't be wrapped as one of the case studies. So I'm not commented about that, but I have commented that she's at the risk of hypertensive disorder. Can you repeat the question, Raymond?
So calcium supplements.
Yes. Yes, calcium. Yes. So again, we don't have definite guidelines. So but we do. Where I work and in my private practice, I do give calcium supplement as well. And there is no harm giving the calcium supplement all throughout the pregnancy and post pregnancy or postpartum period, especially if the woman is going to breastfeed, because good calcium supplement for the neonate or infant as well.
Yeah. And there was one question about the safety of aspirin in baby, but you've answered it, which is that it's relative. It's safe.
Yeah, it is. Yes, it is safe. I wouldn't call it a type A drug because it's not in that, but there is big evidence that aspirin has not shown any side effect on the babies. Like it is 100 milligram only. It's a very small dose. Yeah,
Thanks.
100, 150. So because the aspirin is available in 300 milligrams, so we just advise the woman to break it into half and take it. In UK, when I worked there, or in India, 100 milligram used to be available. So we used to give 100 milligram there. Here we are not having that. So we just tell the woman to take half of 300 milligram, and that is also low dose enough.
Yeah. So I think there are 100 milligrams actually at some pharmacies. So
yeah. So when I started, like in 2011, when we came in here, I really struggled not to give 100 milligram because it wasn't available.
Yeah,
and some of the pharmacies, they don't keep 100 milligrams. So even if they have 300 milligram, you can tell the woman to just take half the tablet. That is also okay. They need to take. That's important.
Fantastic. So there's a few questions in the chat. So at what stage of pregnancy? We mentioned is before 16 weeks, ideally. And how much calcium was one of the questions?
1 gram.
1 gram. Okay. Yep.
So 2 tablets.
Yeah. How effective is HbA1c testing versus OGTT in pregnancy?
Yeah, so I'm going to discuss that in next case.
Next case, okay,
GDM,
all right.
I've covered GDM. So yeah, good point. But we'll cover it in next case.
Yeah. And then with the comment about an anesthetic assessment, how easy is it to get it in a public hospital?
We do it. We get it done. All the patients who have high BMI, we send them to the anesthetic. They have got a clinic. So they'll be assessed in anesthetic clinic. Okay, so not with the 36 BMI because it is a new norm now. Okay, but anybody more than 45, 50, actually 40 is the this thing, but if there are too many 40 BMI patient, then we don't worry about it. Like depending on where you're working. So in the unit where 40 BMI is a rare thing, then they will get assessed because basically everything, the whatever the instrument we're using in the theater, the anesthetist who should be comfortable dealing with that, the staff should be okay with that. All the equipment should be ready for that BMI. Should be, once that patient goes through that clinic, then all these things are flagged. But if the unit is already dealing with more than 40 BMI, we wouldn't worry to send a patient for anesthetic assessment then. Like for that unit, it will be something, 45 or 50. So depending on which unit the woman is delivering with, we follow the protocol. But patients will be assessed for sure near their term.
Oh, that's good. Good to hear. All right. I think we've had all the questions from case 1, so maybe we'll go to case 2.
Okay. So case 2, Rachel, 38-year-old G2P1, comes to you with a history of 8 weeks of amenorrhea. Her urine pregnancy test is positive. This is an unplanned pregnancy, but she is happy to continue the pregnancy. Apart from having mild morning sickness, she is feeling perfectly normal. She is a CEO of management company. Her past cycles are regular. Her past obstetric history, a full-term vaginal birth 7 years ago. She's in stable relationship for 6 months, and most of the time she had used barrier contraception. So what else we need to know about Rachel? Do we need to? Yes, we do need to know a lot of things about her. So past medical and surgical history, that was non-significant. Family history, both of her parents and older sister have type 2 diabetes. Personal history, her job is stressful and she doesn't have time for regular exercise or healthy regular meals. She does not smoke, but she drinks 5 to 6 standard drinks on at least 5 to 6 days a week when she attends her business meetings. She has stopped alcohol intake since she has found out about her pregnancy. She's not taking any medication, and apart from low-risk pap smear, She has not had any investigation in the last 7 years. So do we need to examine Rachel? So all pregnant women need to be examined, like not detailed examination, but at least vital parameters and BMI. So vital parameters, more importantly, blood pressure. So her vital parameters were normal. Her BMI is 29 and rest of the examination was normal. So what risk factors Rachel has? So she's overweight, her BMI is 29. She has got unhealthy lifestyle. She has got past history of excess alcohol intake and she has family history of diabetes. So what recommendation Rachel needs? So folic acid supplement and other routine pregnancy recommendation about lifestyle, and she definitely need a GTT. So she did have early GTT and a fasting plasma glucose was 5.4 millimoles per liter. The cutoff is more than 5.1 millimoles per liter. 1 hour plasma glucose 9.8. 2 hour plasma glucose is 9, and cutoff is more less than like 8.5. So Rachel has GDM. So how do we screen and diagnose GDM? So according to RSCGP, screen all pregnant women at 26 to 28 weeks. The woman at high risk should be rescreened at first earliest opportunity and repeat at 24 to 28 weeks of pregnancy if negative at early stage. So diagnosis is based on 70 of OGTT. So fasting glucose more than or equal to 5.5 millimoles per liter. 2 hour plasma glucose or random glucose more than or equal to 8. Ranzicog diagnosis criteria is fasting plasma glucose in between 5.1 to 6.9. 1 hour glucose more than or equal to 10. And 2 hour plasma glucose 8.5 to 11. So compared to RSCGP guidelines, Ranzicog has a stricter cutoff for fasting glucose levels and ability to make the diagnosis based on 1 hour level. So what management Rachel need? Before that, so if a woman cannot drink plasma glucose, then random glucose is also good according to RSCGP, or they can have one fasting glucose and one HbA1c. So what management Rachel needs? So basically the management revolves around monitoring and normalizing her blood glucose, improving her diet and limiting maternal weight gain. So lifestyle measure about diet and physical activities are the cornerstones. It should be a multidisciplinary team arrangement, and which includes the endocrinologist, GP, diabetic educator, dietitian, and exercise physiologist. So what are the treatment targets for Rachel? So they vary. These are the areas of considerable debate, unsurprisingly. Most maternity centers follow EDIPS guidelines. So fasting blood sugar less than or equal to 5. 1 hour postprandial less than or equal to 7.4. 2 hour postprandial or equal to or less than 6.7. So further treatment is recommended if following lifestyle intervention values exceeded on 2 occasions at a given testing point in 1 week. So how do we achieve these targets? So with dietary advice, so wide range of dietary interventions can be advised, but there is no clear evidence to support one particular type of advice. So while giving dietary advice, we should always remember or keep in mind that which ethnicity a patient is from. So there is no point advising a Mediterranean diet to an Indian woman. She's not going to follow. So it's better to keep in mind what ethnicity she is from, what are her choices. So most important word, patient-centered approach, which GPs follow better than specialists. Regular monitoring of weight gain, regular monitoring of weight gain and hunger are the keys. The type, quantity, and distribution of carbohydrate can be adjusted according to the postprandial blood glucose levels, and accredited dietitian involvement is important. Physical activity, 30 minutes of moderate activity 3 to 4 times a week, recommended for all pregnant women. So especially after having each meal, if they can do it, even inside the house. If they can't do it for 30 minutes, even 10 to 15 minutes activity will bring their blood glucose down postprandial. Straight line activities like walking, jogging, swimming, cycling, and strength training are generally safe. There are very helpful Ranzicog guidelines. Anybody can go on Ranzicog website and download those. So if this doesn't control Rachel's BSL, then she needs pharmacotherapy in terms of either metformin plus or minus insulin. And what other advices should be given to Rachel? So early referral to maternity services, as this is a high-risk pregnancy. Referral to dietitian and diabetic educator. Watch for complications like complications for high-risk sugar, for example, infections, pregnancy, instrumental or operative deliveries, fetal microscomia and its complications, increased risk of type 2 diabetes in later life. And what else she needs? So she needs a growth scan at 28, 32, or 36 weeks of pregnancy, depending on severity of GDM and what protocol your maternity services follow. Careful diabetic monitoring if steroids are required during pregnancy, because that's going to increase her blood sugar. Induction of labor before 40 weeks of pregnancy, depending on severity of her diabetes, microsomia, and how well her blood sugars are controlled and what dose of insulin is she taking. Watch for neonatal hypoglycemia, especially if the microsomic baby is there. Encourage her to breastfeed. That will help her diabetes as well as improve the baby's hypoglycemia. OGTT in between 6 to 3 weeks of postpartum. Long term, how are we going to manage her? Either do annual HbA1c or annual fasting blood sugar level or annual OGTT and advise weight loss. So that is about case 2. If anybody has a question, I'm more than happy to answer them.
Yes, we've got a question that's come in already, which I was also thinking of, which is what is the time frame for lifestyle modification before we decide that she needs to start on medication?
Oh, any lifestyle modification?
Yeah.
They are from any time. Even if she goes on insulin, those are very, very important. So like if a woman is not doing any exercises, for example, so those who are already doing the exercise, they can continue doing exercises, but you need to inform them that like they should not get very hot. Like, for example, if they're doing hot yoga, so you should tell them that you should not get very hot, because whatever temperature the mom is having, the bub is going to be 2 degrees more, and that can increase the fetal heart rate and can be dangerous, or not. Like if they are having very high intensity exercises and then coming home and going into hot bath or a hot shower can be dangerous. So these should be kept in mind, but otherwise they can continue whatever the exercises they were doing. They should not add any high intensity exercises. But those women who are not exercising, they can at least start walking, if not jogging, but stretching, muscle strengthening exercises with 2 kg or 4 kg weight gradually. They can start doing those things. And as I was saying, that if they can't go out of the house after every meal, even 15 minutes of stroll inside the house has shown a lot of evidence to bring their blood sugar down postprandial. Yeah. And most of the women do struggle to bring their postprandial blood sugar. So that we can manage by doing some, even inside the house walk.
And how long do we wait before we decide on starting insulin?
So as I had mentioned, if they are having, like after lifestyle modification, if they're having 2 readings of high blood sugar, the cutoff I have told you, the fasting more than 5.1 and postprandial more than 6.7 on 2 occasions in 1 week, then they need to go first on metformin. If metformin is not working, then we start them on insulin.
So basically, once you detect it, if they exercise in that week following you've advised them, if they've reached the criteria more than twice, you go straight to metformin. Yeah.
Yes.
Yep. Okay.
There is, yeah, it's better to start it early than later because babies gain weight very fast. And if blood sugar is high right from second trimester, we know that these babies can have some congenital anomalies. We don't want to have that. Like if the blood sugar is pretty high, we would send them at around 22 weeks for fetal echo to find out if they have any cardiac anomalies. So type 2 diabetes who are uncontrolled before falling pregnant, these women's pregnancies or fetuses are more risk of having some cardiac abnormalities. So we don't want our patients to have those risks. So there is no harm doing exercises. So that is the actually benchmark that you need to push them more and more for doing exercises. Even stroll inside the house. That would do.
Now I've got a few questions. So I see a lot of women with low BMI who are fit normally who get gestational diabetes. So I think this is a question about why that happens and the pathophysiology of that.
So basically, see what happens when a woman gets pregnant. Like the pregnancy growth needs more sugar. So the human placenta develops a some hormone, a lot of hormones. We are not going to go in detail because it's a very favorite topic of mine and we can discuss this later. If I start talking, I'll not able to stop for next 10 minutes. So these hormones, then they reduce the barrier in placenta so that fetus can absorb more sugar from the mother. Okay, so these hormones are anti-insulin. So they go in mother's body and they reduce the activity of insulin. So that helps a bulb to grow. So even if their BMI is low, but they are not having a healthy activity, like habits, like not eating healthy food and not exercising, then they are also pre-diabetic. Weight is not just a criteria. So lifestyle is very, very important. If they are managing their weight by not eating properly and eating high calorie or high sugar diet, they are still at the risk. So if they're having bouts of sugary meal and then keeping themselves hungry, that's going to be having irregular blood sugar. And then this unhealthy environment in their body will be pushed further by the human placental lactogen. And that is going to cause diabetes in these women. And this is what is happening, that most of the thin women, like those who are having low BMI for 18 or 19, they don't do it through healthy lifestyles. They do it by starving and then having pulses of high calorie or high sugar diet. And we do come across such women. So again, lifestyle modification. We can't run away from them. Yeah.
Thanks so much. So there's another question about metformin in pregnancy. Is metformin prescribed in pregnancy?
Yes. So actually, Queensland Health, metformin is prescribed very commonly in most of their hospitals. Okay, so some of the units prefer giving insulin. Most of them, like where I work in Northern Hospital, we give both. So diabetic patient are managed by dietitian, diabetic educator, endocrinologist, and obstetrician and obstetric team. So when the patient comes for the appointment to the hospital, they have got appointments on the same day to 3 people at least. Endocrinologist, diabetic educator, and obstetrician. So the patient will be seen by endocrinologist and then they start on metformin and then they come back to us, the obstetrician. And then we look at the ultrasound scan. And then if the baby is microscopic and not having good control, then we talk on the same day with the endocrinologist and then discuss whether this woman needs to go on further insulin or not. And they are managed there only. So yes, metformin is given very routinely.
Yeah.
Yeah.
I think I was just looking up this matter because of all the questions and I guess previous knowledge. I think it's a bit it used to be a bit controversial, but some studies have really shown that metformin's safe.
Yes.
Yeah, I'm just looking up therapeutic guidelines. It says some specialists recommend against because it crosses the placenta, but however, randomized controlled trial has shown metformin
correct.
was safe. Yeah.
Yes.
Yep,
So the thing is, again, so there is no definite guideline, but lot of evidence, the women all over world are been studied for metformin and outcome during their pregnancy, and there is a lot of positive outcome. So more and more, like 10 years ago, diet and insulin, that's all we used to do. But since last 4 to 5 years, we are giving more and more women, we are giving metformin, and the outcome is really good. And then women also feel that if not directly exposed to insulin, because it's very stressful to start insulin. Many women are not very happy to go on insulin, so that is a psychological effect of giving metformin as well, that okay, let's start with oral. Meantime, you continue doing your lifestyle modification. If that is not working, then there is no option but to insulin. It's easier to then counsel the woman. You know it better than a specialist, that how it's difficult for patient to convince and make them take the insulin. Compliance is very difficult. So that way also metformin helps.
Yeah, fantastic. I'm glad we managed to clarify that of some of the anxieties around that from the questions. Yeah. So moving on to other questions in the chat. When do we recommend folic acid tablets? Is it only GDM preeclampsia? If so, what dose? So obviously we need folic acid, it's routine, but I think maybe it's a question around the dosage.
Yeah. So routinely, ideally 3 months pre-pregnancy, but at least 1 month before the pregnancy. Okay, so that is must. Pregnant women who are obese, I discussed that. Those who are even overweight, those who had and previous history of Down syndrome or neurological defects, those who are hypertensive, had shoulder dystocia, those can be started with high dose of folate, 5 milligram.
Fantastic.
Yeah.
All right, great. That's nice and clear cut. I think that's all the questions for the case 2. So maybe we should move on to case 3.
Yeah. Case 3, Nina is 21 years old, university student, comes to you with the history of past. So last menstrual period was 6 weeks ago. Her past menstrual cycles were regular. She used to bleed for 4 days every 28 days. She's getting mild period-like pain, otherwise feeling okay. She's in stable relationship for 3 years and uses a withdrawal method for contraception. She doesn't have any significant past medical, surgical, medication history. What do we do next? Is the clinical examination important for diagnosis? Clinical examination, more than that, office test. So we need to confirm that she's pregnant. That is the most important thing. So Nina's examination findings are her vital parameters are normal. Her BMI is 24. Systemic examination is normal. Per abdominal examination is soft. Vaginal examination she declined. And urine pregnancy test is positive. So Nina is pregnant and she is having vaginal bleeding. So this is a type of miscarriage. So what are the types of miscarriages? So threatened, a pregnancy complicated by vaginal bleeding and little or no pain, less than 20 weeks of pregnancy. Incomplete, failed pregnancy, in which the uterus may still contain fetus, placenta, or membranes. Complete, a failed pregnancy in which a fetus and all products of conception have passed out of the uterus through the vagina without need of medical intervention. Missed, a pregnancy that has stopped progressing but without symptoms of pain or bleeding. So, septic pregnancy loss complicated by uterine infection, ectopic pregnancy, fetus growing in an extrauterine location, blighted ovum, and embryonic pregnancy, early pregnancy loss with a present gestational sac but no fetus, Recurrent, more than or equal to 3 consecutive losses. Many professionals argue that investigation is warranted after 2 successive miscarriage. So Nina has threatened miscarriage. So what further investigation she needs? So she needs pelvic ultrasound scan, beta HCG quantitative and blood group. So Nina's pelvic ultrasound scan shows empty sac of 25 millimeter in size with subarachnoid hemorrhage with suboptimal beta HCG level. Her blood group is B positive. So she had threatened miscarriage and she has threatened miscarriage. It is due to miscarriage. So she's got empty sac with no fetus. So manage her. So management is information, support, advice, and it can be expectant medical surgical management and consider giving anti-D, but Nina doesn't need because her blood group is positive. So suitable expectant management, suitable for incomplete or inevitable miscarriage with no heavy bleeding, wait and see approach, should only be limited to first trimester miscarriage due to risk of hemorrhage. With adequate time, around 8 weeks, it will be successful in up to 80 to 90% of women. Follow-up, repeat beta HCG at 3 weeks after pain and bleeding has ceased. If it is still positive, consider doing serial beta HCG until negative, plus or minus ultrasound scan to exclude retained products. Medical or surgical management needs to be considered for rest of the 20%. Medical management indicated for women who have failed expectant management, those who wish to shorten the time to complete products of conception expulsion, and women who do not wish to have an expectant or surgical management. So initial dose of 800 microgram isoprostol per vaginal. If a woman is bleeding, you can give her orally subbuccally. That can be repeated at least 3 hours later. Contraindicated in asthma and hypertension, and follow-up ultrasound scan within 7 to 14 days or serial beta HCG level. Surgical management, evacuation by suction evacuation, done under general anesthesia and most centers. Rare complications of bleeding, infection, uterine perforation, 1 in 200 patient. Preferred by some women as it provides more immediate resolution, requires less follow-up, and permits diagnostic testing such as karyotyping of the product of conception. So what further treatment? So giving these either medical, surgical, expectant management is enough? No, she does need psychological support, even though it is her choice. Like she wanted to have miscarriage, termination. Even if she was pregnant, she will still need psychological support because it's quite stressful thing, which I'm sure that's what GPs do very good. Very well. And contraceptive advice for definitive contraception. Withdrawal method is not good enough. She needs definitive contraception advice. So that concludes my case 3.
If everyone could put some related questions in Q&A, that'd be great. So first of all, Q&A question was, could you explain missed pregnancy? I think that means missed miscarriage.
Yes.
Maybe we'll go through that again just to be clear.
Yeah. So what happens is that pregnancy doesn't grow in that. So that means almost 15%, like 15 out of 100 women can have abnormal pregnancy. The chromosomal abnormalities are there, and then that cases the miscarriage, missed pregnancy, like missed miscarriage happens. So that means the pregnancy is there, but the fetus or embryo doesn't develop. So this is very tricky, and that's why Ranjagog has revised the guidelines for the size of the gestational sac. So previously, around 5 to 6 years ago, the cutoff was 20 millimeters of MTG sac. So what used to happen, like if the early pregnancy is there, the pregnancy will be seen only as an empty gestational sac. So what happens when the pregnancy is there? First, the G sac develops, then the fetal pole develops, and then the cardiac activity comes in there. So these are the steps. So if you see the woman whose gestational age, like her from period from her last menstrual period can be 8 weeks, but her pregnancy can be just 6 weeks or 5 weeks. In that, her G-sac will be still empty. Okay, so you can't diagnose that now her G-sac is empty, so she's bleeding, so she's miscarriage. You can't unless the G-sac is 25 millimeters in size. Okay, so that is a cutoff. So once there is a G-sac and there is no growth, like that is one of the cutoff, that the G-sac is 25 millimeters and there is no fetal pole. The other cutoff is that you have done one ultrasound scan and after a week you have repeated it and there is no increase in the size of the G-sac. That is also cutoff for miscarriage. Or third is falling beta hCG titers and patient is having bleeding and all the signs of threatened or incomplete miscarriage, and G-sacs can be then 20 millimeters. Okay, so that is 3 things. Now, what is next thing? Like G-sac is there and fetal pole is there. Now, what are you going to do? So if the fetal pole is more than, it's 5 millimeters and G-sac is 25 millimeters and there is no fetal cardiac activity, then again, that is a miscarriage. Then you can recommend her the further treatment. So these all guidelines are there in Ranzikov website. Anybody can access them. So you have to just type the statements, Ranzikov statements, and you can get those, all the guidelines. So yeah, that's important because we don't want to advise any medication or medical treatment if it is early pregnancy and if it is wanted pregnancy. It is a disaster.
Absolutely, yeah. All right. Now, I don't think there's any specific questions around the case, but there was a question around a GP has had a few patients recently who have been told by their naturopath that they should not have folic acid due to FGR gene mutation. Is there any evidence about this, or is that more just something we should kind of counsel patients to, well, take their folic acid, I guess?
Yes. Yeah. Please. Okay. So no, there is lots of evidence that this definitely works.
Yeah.
Okay.
Fantastic. Yeah. A good question. When to give anti-D in miscarriage?
So we usually give them, like if you're going, it depends on the expectant management, you can give them directly. Okay. Medical termination, what we do is that when the patient comes to us, we prescribe them the medication and we send them directly for anti-D. So that, and surgical termination, same day. So same day when you are giving her treatment, you can give her anti-D. If she's come back later, then latest you can give it up to 96 hours. So 250 international unit of anti-D can be given. Yeah.
And I guess the corollary of that, just trying to refresh my own memory, actually, when there's threatened when there's bleeding in pregnancy, which is may not be a miscarriage, it's just threatened miscarriage. What age, what gestational age do you need to give an anti-D?
After 12 weeks.
After 12 weeks. Yeah. Okay. Yeah. Fantastic. Yeah. Thank you. Yes. So that was one of the questions that just came through. Anti-D given any gestational age. It's actually from 12 weeks onwards if it's just threatened.
And after 12 weeks, every time she bleeds, we will consider giving her anti-D, unfortunately.
Yeah.
And if she has bled more, before we give next anti-D, we do anti-D titers. If she's sensitized, then there is no point giving anti-D. So it becomes a very complex situation then, and then we involve the feto-maternal unit if the patient's anti-D titers are high.
And how many miscarriages are genetically tested?
See, there is a evidence that all the public hospital and we follow Ranzikov guideline very strictly, and we start investigating only after 3 miscarriages. But if patient is in my private practice, I start investigating from second miscarriage. So if a patient comes with a history of first miscarriage and now she is aborting or miscarrying, I would send that to karyotyping. The only thing is that karyotyping is very expensive. It costs $600 out of pocket. There is no Medicare rebate on that. And if we are doing karyotyping for the abortus, then we need to do karyotyping of mom and dad as well. So the cost goes quite up, and it can take up to 10 weeks for getting back that report. So you need to tell all these things to the patient. And then the abortus should be collected in saline, should not be collected in formalin, and you need to be informing the lab that you're going to send it, ASAP. All these things should be taken into consideration, because if the decomposition starts, then it's very difficult to know what is the genetic type. So it is expensive, but it's a good tool to know. It's not very common to find out abnormality, but if we find out, then we definitely know what needs to be done.
All right, I think that's the end of the questions for case 3. So maybe we'll move on to the next case.
Yeah. So these are the breast problems. So case 1, Paula is 48-year-old G1P1 patient with a history of lump in right breast for 1 week. Menstrual history, last menstrual period was 2 weeks ago. Past menstrual cycles were regular. Sexual history, she's in stable relationship for 20 years, using combined oral contraceptive pills for 17 years. Obstetric history, 1 full-term vaginal birth 18 years ago. No history of breastfeeding present. Past medical, surgical, psychological history is not significant. What else we need to know about Paula? Is this history sufficient? No, we need to know about family history. So sister had breast cancer at the age of 50 years, doesn't know if she had any genetic problem. Her cervical screening test 1 year ago was low risk. All past pap smear were normal. She's a smoker for last 10 years, smokes 20 cigarettes per day, doesn't drink alcohol. So does Paula have risk factor for breast cancer? Yes, she does. So she has history of smoking. She has first degree relative having breast cancer. She has history of long-term use of combined oral contraceptive pills and history of not breastfeeding. So breast cancer risk factors, moderate to strong risk, increased risk, female gender, increasing age, family history of BRCA genes, highest risk, breast condition, previous breast cancer, atypical hyperplasia, lobular carcinoma in situ, high breast density, high endogenous estrogen levels, and history of radiotherapy, and modest increased risk, HRTs, oral contraceptives, being overweight, obese, postmenopause, tall stature, smoking, alcohol consumption, hormonal and reproductive factors, early menopause, early menarche, late menopause, nulliparity, and no history of breastfeeding. So Paula's examination findings: general examination, vital parameters normal, her BMI is 24, cardiovascular, respiratory, per abdominal, liver, spleen not palpable. Breast examination, right breast showed 1 centimeter of firm to hard, irregular, mobile, non-tender lump in inner lower quadrant. No nipple discharge present. Pudor orange sign absent. Left breast, bilateral axilla, supraclavicular areas were normal. Are there any red flags in this examination? Yes. So red flags is firm to hard irregular lump, which needs investigations. So what are the red flags? Distortion or tethering with or without lump, firm immobile lump, skin dimpling or pudor orange appearance, spontaneous unilateral bloody or serous discharge from a single dart, changes to nipple, eczematous rash, it's with recent inversion, and lymphadenopathy. So investigation of a new breast symptom, a triple test approach to the diagnosis should be used in all patients. Medical history, clinical examination is very important. Imaging, mammogram and or ultrasound scan, non-excisional biopsy, core biopsy, and or a fine needle aspiration cytology. When performed appropriately, a triple test will detect more than 99.6% of breast cancer. Negative triple test, the cancer is unlikely, less than 1% chance. So what test Paula needs? She needs triple test. Triple test, ultrasound scan and mammogram for both the breast and axilla. Ultrasound guided fine needle biopsy, aspiration biopsy, core biopsy if needed. So her ultrasound scan showed solid lesion and mammogram showed stellate soft tissue lesion. FNA confirmed malignancy and Paula was referred to breast surgeon for further management. So what is GP's role in this management? So managing side effects of the treatment, surgical, chemotherapy or radiotherapy, emotional and psychological support to Paula and her family through mental health care plan, and surveillance follow-up with continued psychological support. So the specialist will not just manage the disease, the life and the family life and like a holistic approach to whole treatment is by GPs. So that is this case. So I'm happy to answer if there are any questions.
Yeah, there was an interesting question about the link between tall women and breast cancer.
Yes, I thought that somebody will be asking. I don't know. There are few things which we don't know actually. Even, for example, why breastfeeding is important. We don't know. We have found out there is a lot of studies, especially in European. There are a few European studies which have linked tall stature to breast cancers. We don't know exactly. Same with the breastfeeding, but there are some hypotheses that because breastfeeding is done, whatever secret, cells are there in the ducts are washed out for those periods of time, and then there is a less chances for women to develop breast cancers. So these are hypotheses. There is no definitive causation. This is an association actually. It's not a cause, but these are red flags. If a woman comes with lump and if she's tall, if she has not breastfeeding, there is no history of breastfeeding, or then we need to investigate them further. We don't know, frankly speaking. Good question. I'm sure that they'll come up with more. If more evidence is there, then they may be coming up with some genetic studies which helps women to grow, and same genes causes breast cancer.
Yes.
Yeah. So more we know about the genes, more we'll come to know if there is any linking.
Now, a good question around risk calculators. Do we still use tools such as FRABOC and also CanRisk, another one?
So whatever tools you are used to, you can go ahead and use those. But I think just sticking it to triple test, this is a new guideline, make your life simpler. So stick to triple test, and that's what you need to do. History, clinical examination, ultrasound scan, and then if needed, this thing. So breast screening of Australia is following that. So that more and more evidence is coming that this is what we need to follow. And in at the end of my presentation, there are a lot of sources. You can go through that, and that's what we are recommending. Yeah.
Thank you. There's a question around screening. So if ultrasound already suggests dense breast tissue, do we need to proceed for a mammogram if there's no obvious mass on palpation?
Yes. So unfortunately, dense breast, the thinner women have dense breast, and that is the high risk, not because of the dense breast, but because it's very difficult to find out if they have any growths. So less than 40 years, the recommendation are to do the ultrasound scan, and more than 40 years, then the mammogram should be done. But then if the woman is having dense breast on ultrasound scan, they should be having the mammogram. But usually the recommendation are done by the radiologist. If you send a patient, if you are feeling any mass or lump there, and if you send them for the ultrasound scan, and if they can't see anything, they would themselves will do mammogram. So it's not harmful if you just write ultrasound scan plus or minus mammogram. So the radiologist will not contact you. They'll just go ahead and do the mammogram.
Yeah, that sounds like a good one, the plus or minus.
Yeah.
Katharina asked, should we screen women between 40 to 50 who are on oral contraceptive pill with a mammogram instead of waiting until 50 years of age?
Yeah, so that's also a good question. Yes, one baseline mammogram is allowed at that age if woman contacts breast screening. Okay, so that is covered by Medicare. Okay, otherwise mammograms are not covered. COCP, I have included that in my presentation, and there is a data, but if you like, if a woman has, now this is not related to this presentation, and if you want, we can have more presentation about cervical screening, another favorite topic of mine. So if a woman comes with the abnormal cervical screening test and or cervical cancers or breast cancer, then we always ask whether they have used combined oral contraceptive pills or whether they have HRTs. But when the woman come for combined oral contraceptive pills, apart from briefly mentioning, we don't mention it because there is no clear-cut evidence that a short-term use, like 5 years of use of combined oral contraceptive pills, is actually protective for tubo-ovarian cancers, and there is no increased risk of breast cancer. But a woman using oral contraceptive pills for longer than 5 years, 10 years, 17 years, there is a risk. So, and you should counsel them about using alternative method of contraception. And if they have decided not to have children, it's okay to inform them to undergo permanent contraception like tubal ligation, or their partner undergoing vasectomy, or using Kylina or Marina. Very good option, especially now because Marina can be used for 7 years now. Okay, so yes, why not? Yes,
yeah, that's right. That changed the guideline.
Yeah, after 40 years, you can have one baseline mammogram. In actually, American guidelines are you do mammogram from the age of 40 years.
Yeah.
Yeah.
So no clear-cut answers is, by the sounds of it, in terms of clear-cut recommendations, but a baseline is possibly
one baseline,
useful.
not regular. One baseline mammogram is, we need to, like, it costs $150. If a woman is okay to screen, then she can have every couple of years. But Medicare will cover only once.
Yeah. Now we've got a question around triple test. So if the lump is palpable, but the FNA comes back as non-malignant, the triple test is still positive. Do we refer to a specialist?
Yes.
Yes. Yep. Yep. Great. Is there any specific time period of breastfeeding to prevent breast cancer?
I didn't get it. Like duration?
Duration of breastfeeding.
Yeah. So a longer is better. So breastfeeding guidelines, good for mom and child, ideally 2 years, which is very hard to follow. But even 3 months breastfeeding is good enough for mom. So not only it helps woman's health for her diabetes or her overweight, but that is known to be protective. As short duration as 3 months is good enough. So like Prami Gravida who just delivered and struggling to breastfeed, you should stress saying that I know it is difficult, but it's going to be helpful for you in 2 ways. First, it will help the weight, the diabetes, if she had diabetes, breast cancer, and more she tries this pregnancy, more confident she'll become for next delivery, and she will continue breastfeeding longer than 3 months after next delivery. So as short as 3 months will be good enough.
Oh, that's really good. There is
evidence, yes.
Yeah, fantastic. 3 months is not too long. Now, 2 more questions in the chat. So a question about whether, I think that's meant to say Dutch heritage having high incidence of breast cancer. Is that right? Yeah.
Yes, it is. And again, they don't, that's why most of the Dutch studies are related to breast cancer and how to do that. They are small studies because their population is not big, but they are important because they have done lot of studies and they are multicentric and different causative factors they have studied. So they're important. So what was the question?
Oh, it's just clarifying whether they have a high incidence of breast
Yes,
cancer.
they do
Yeah,
have
yeah,
a high
yeah.
incidence, and
Yeah.
again, they don't know why.
Mm.
They are acting on all these factors, breastfeeding, and trying to use more marinas or kylinas so that they're not using combined oral contraceptive pills. And now they know more about it. So next 10 years are going to be more interesting to know how their incidence is.
Yeah, there was
Yeah.
space to watch then.
Yes.
And then finally, what about MRIs for breasts?
This was another which I thought will be asked. MRI is a very good tool, but depending on how the radiologists are in your center are confident, because they need to be really well trained to look at those lesions and confident enough to tell us that those lesions are malignant. Okay, so MRI, like those patients who have got not so sure mammogram and FNA is not conclusive, those patients can be referred for MRI, but MRI can't be used as a screening tool because of cost effectiveness. So screening test has to be cost effective to apply to the larger population. That is one of the criteria for selecting a test as a screening test. So MRI is very, very expensive, and that's why it can't be used as a screening test. And it needs a lot of training to the radiologist because they are not done in large number. There are not a lot of radiologists which are exposed to that kind of experience. So it's a catch-22 situation.
All right, I think that's the end of the questions for this case.
All right.
Maybe we'll move on to the next couple of cases given the time.
Sure.
Yeah.
So Jane, this is my field. Jane is 32 years old, nulliparous woman, comes with a history of pain in her breast for 10 to 12 days before her menstrual period for last 8 months. Very, very common presentation of GP practice and gynecology practice as well. She always used to get this pain in past, but it has worsened over last few months. The pain is accompanied by tenderness, fullness, heaviness in her breast, and it disappears when she starts menstruating. She has started taking Panadol for her pain without any relief. Her friend's sister is recently diagnosed having breast cancer, and Jane is really worried about it. What else we need to know about Jane? So about her menstrual periods, her last menstrual period was 3 weeks ago. She bleeds for 4 to 5 days every 30 days. She's in stable sexual relationship for 10 years. She has had a tube tied after having 2 children 6 years ago. Her past medical, surgical, family history is not significant. She has had low risk pap smears. The last one was 1 year ago. She's a housewife, non-smoker, and drinks 1 to 2 glasses of wine every 1 or 2 months. So what is she suffering from? So she's suffering from cyclic mastalgia. So cyclic mastalgia is the most common form of mastalgia. It varies with the menstrual cycle, increases progressively from mid-cycle during the luteal phase, and usually relieved with the onset of menstruation. This can be one of the symptoms of premenstrual syndrome. Most likely, it is due to water retention, the stroma of the breast, and mediated by progesterone, usually located in upper outer quadrants of the breast. It is often bilateral. It's often described as a discomfort, fullness, or heaviness with a dragging or aching quality. So what do we do next? We do need to examine her. So apart from mildly tender breast, her vital systemic examination, breast and axillary examination are normal. So what advice Jane needs? If it is cyclic long-standing pain, she does not need triple testing. So we can recommend review in 6 to 8 weeks time, especially in early menstrual cycle. If it is something new and in early menstrual cycle also she's having tenderness, then you can get the triple test done. If triple test is negative, then reassure the patient. Advise patient to wear a well-fitted bra. You can try giving evening primrose oil. There is some evidence in randomized trial that evening primrose oil reduces mastalgia in some women. You can give 1 gram 2 to 3 times per day for 2 to 3 months. That's what is usually required. Other supplements, diet, there is the evidence does not support the recommendation of vitamin B1, B6 or E or any other supplements or specific diet for mastalgia. High caffeine intake has been linked to mastalgia, but research has not been conclusive. For analgesic support, use simple analgesia like paracetamol, orally or topical anti-inflammatory, especially if only required for a few days each menstrual cycle. Oral contraceptives. Some women find that their mastalgia improves with COCP, while others find it exacerbating symptoms. High doses of estrogens are more likely to cause mastalgia. So other hormonal medication for severe cases of mastalgia, medication like danazol, tamoxifen, bromocriptine are of use, though their use is limited by side effects. Patient being considered for these medications should be referred to specialists, breast surgeon, gynecologist, or endocrinologist for further discussion. Complementary therapies. Some women get relief for relaxation therapy, acupuncture, other complementary therapies, but their role is not very clear. The other uncommon case is the breast pain is caused by large cyst or fibroadenomas. Aspirating or removing these can be relieve the discomfort. So happy to answer the questions. Very, very common presentation of GP practice.
All right. We don't have any questions yet, but a question about the last case. Just wanted further information about MRIs for the young with BRCA gene.
Ooh, how young?
There's no information about how young. Yeah.
So yeah, you can get a yearly mammogram done. Okay, if patient is wanting, but as I was saying, that it's not a very good screening test. So if she is having BRCA genes, then she should be sent to a genetician and get the counseling done. Once she finishes her family and if she has BRCA1, then she can be counseled about bilateral mastectomy. And if she has BRCA2, then she should be counseled about bilateral. If she has not completed family, if she's too young, then at least bilateral tubectomy, if not oophorectomy. So once she hits 40 years, then we can counsel her for bilateral tubo-oophorectomy. So yeah, very drastic step, but these patients have got almost 45 to 60% of developing cancers, and those cancers are very aggressive. Angelina Jolie is one of the examples. I'm sure you guys must be knowing that.
Yes, I was going to mention that as a as a classic example of
yeah.
Now Jacqueline has asked, why does higher estrogen medications aggravate breast tenderness when most cases of mastalgia occur when estrogen is falling?
Yeah, so this is again a hypothesis that so basically all these symptoms happen when women get pregnant because there is increased blood supply and increased hormonal support to the breast, like the stroma gets more blood supply by progesterone support. So that's what happens. But the woman who have pain, even in premenstrual period, those women are going to get more pain with COCPs. Those who are typically having pain only in a couple of weeks of her menstrual cycles after ovulation, they are going to feel better. But you need to remember that COCP has got progesterone as well. So it becomes really, really tricky whether they are going to feel better with COCP or not. So not all patients will have more pain with COCP. Those patients who have pain in pre-ovulatory period, these patients are more likely to have pain with COCP. So it depends on, do I make sense, Raymond?
Yes, I'm following.
So okay, let me phrase it in different way. So what happens after ovulation? Progesterone is formed. So this progesterone acts on the breast, making them ready for pregnancy. Okay. And those women are more sensitive for that kind of changes during corpus luteal phase. Okay, like last 2 weeks of menstrual cycle, when the progesterone goes up. And then when they fall pregnant, it keeps on increasing and that develops a breast. Okay, so it's like a pregnancy situation for them, but they are more sensitive for that kind of, like they are very sensitive about the changes in the breast. Okay, but for unknown reasons, some of the women have this same feeling or same pain even before ovulation. So then we get confused about why this pain is there. You know, if we think that premenstrual syndrome or mastalgia is because of only progesterone, these women should not get pain in pre-ovulatory phase when estrogen is there. Okay. Now these women, if you put them on COCP, are not going to get relief. Because you're giving them estrogen also. And it's a little bit higher estrogen than what the body is having.
So
okay.
Jacqueline's followed that up with most of the women she sees with breast tenderness are premenstrual in their tenderness.
Yes.
So yes, yeah.
So they might get better because their progesterone is higher than what we give in combined oral contraceptive pills. Do I make sense?
Sorry, they might get better with.
Yeah. So we are, by giving combined oral contraceptive pills, we are suppressing their endogenous progesterone. Okay, so that endogenous progesterone is acting on their breast and causing these symptoms. So if we give exogenous progesterone, that is going to suppress the ovaries to form their own progesterone, and these women then feel better.
Yes. Sorry, I was getting confused between pre-ovulation and premenstrual. Yes, that makes sense now. Yes.
Yeah. But okay. As I was saying, that this is a logical explanation. But there are some women who typically get pain premenstrually, and in those patients, they don't get better with the COCP, unfortunately. And these are the patients which we see, a gynecologist.
Yes. Yeah. All right. I think that's all the questions. Now, do you think we can squeeze in the final case, or is it going to be? Yep. Okay. Maybe we'll just talk through the final case. Yeah.
10. Because that is also a common presentation, but I don't think a lot of people will have a lot of questions, but let's go through it.
Fantastic.
So Tina is 16 years old, grade 11 student, as she has found a lump in her breast. Left breast last evening. She doesn't have any pain in the breast or discharge from her nipple. She and her mother are anxious as Tina's grandmother died of breast cancer at the age of 92. Tina has a regular menstrual cycle. She is not yet sexually active. She doesn't have any positive past medical, surgical, or medication history. She's a happy young lady and enjoys going to school. So what do we do next? We examine Tina. So vital and systemic examination is normal. A left breast, upper quadrant, 2 centimeter non-tender, firm, mobile lump is there. Rest of the left breast and right breast bilateral axillary examination is normal. So most likely Tina has fibroadenoma. So what do we tell Tina about fibroadenoma? So we should inform Tina that fibroadenoma, as they are a benign solid tumors arising in the lobules containing glandular and fibrous tissue. 12% of all systematic breast masses are fibroadenoma. It is most common in the age of 15 to 35 years. The peak incidence is around 21 to 25. Etiology is unknown, likely a hormonal relationship known to fluctuate during the menstrual cycle and during pregnancy. It can be tender, particularly premenstrually. Usually they are singular, can be multiple. They're classically round or oval, firm and rubbery, smooth and very mobile. They're called as breast mouse. Complex and multiple fibroadenomas are associated with increased risk of breast cancer, 1.5 to 2-fold increase. Juvenile fibroadenoma can occur in teenage girls. That's what has happened with Tina. So what investigation Tina needs? So she needs ultrasound scan. So fibroadenoma appears on ultrasound scan, well circumscribed masses with smooth contour, does not disrupt the surrounding breast architecture, and does not have posterior shadow. So that's it. There is no, so usually the breast shadow is typically like this. So no posterior shadow. So what is the treatment for fibroadenoma? So new palpable lesion in women more than 40 should be considered for biopsy, even if benign, on triple testing, as the likelihood of new lump being breast cancer increases with age. Women less than 40 with a new lesion, if benign, on triple testing, either surgical excision if causing significant discomfort, or regular ultrasound scan and clinical review until stable. Impalpable lesion or incidental findings, if not concerning, imaging features, then imaging surveillance for every 6 to 12 months until they are stable. And then you can do it 12 monthly or 2 yearly. So that's it about fibroadenoma.
Thanks. Thanks so much, Vaishali. Any questions from our participants, attendees tonight? All right. Now we've got the link to the reviewing performance questions that Nazia's just put on the chat. So that's for completing the reviewing performance questions tonight. Whilst we're kind of waiting for further questions, I think for our attendees, if you click the link, make sure you answer those questions so that we can document your attendance and reflection on the session. Do we have any questions about the case around fibroadenomas? So Jacqueline had a comment. I'm not sure I understand the question. Is she's 16, not less than 40? Is there any further extra part to that question, Jacqueline? No, I think maybe it was a comment around the fact that it's okay. So, sorry, Dr. Bhalerao, I interrupted you. Yeah.
No. So in Tina's case, I would just do imaging 6 monthly, twice, and then 12 monthly. And once it is stabilized, if it is not growing, I'll just do every year or every couple of years. But if there is any changes in size, or if she starts having some discharge from nipple and all those things, or develops some nodes, then definitely she needs further investigations.
Yeah.
Yeah.
Yeah. Fantastic. All right. Well, it's 2 minutes to 9. I think everyone must be kind of ready to get ready for bed. That's why no more questions. But I really wanted to thank you, Dr. Bhalerao. That was really, really informative. And it's refreshed my knowledge of obstetrics in particular, which is always really helpful for my shared care practice. So that's fantastic. Thank you so much.
My pleasure.
Thank you, Dr. Vaishali. It's been really, really interactive and nice. It's really an honor. Thank you.
Yeah, thank you for organizing. All right.
All right. Well, if there's no further questions, we'll leave the chat open for everyone, just so that they can see the link. We'll put the link again into the chat. But otherwise, have a great night to everybody. And thanks to our presenters, Dr. Vaishali Bhalerao and Dr. Venugopal. Have a great night, everybody.
Good night. Thank you.